हाँ जी सर, हाँ जी सर. Good evening sir, good evening ma'am.
Hi Siddharth, how are you?
All good ma'am.
So सिद्धार्थ हम लाइव हैं, बस मेरे ख्याल से और 5 मिनट में आप शुरू कर लो. मैं 1 सेकंड में YouTube पे देख लेता हूँ कहाँ पहुंचे.
Okay sir, done sir.
Hello everyone who is joining us on YouTube right now. We are here with the first session of NEETPG, recall, and we will be dealing with the answers that we feel are the most likely answers based on the recall that we have created. But I want all of the children to understand. I want all the children to follow that we are dealing with recalled questions. It is very important to understand that in the actual exam the question framework versus what the students recall sometimes is different. So, and second thing is, I do not want you to use this as a speculative tool and you start speculating कि अभी तो मेरा अच्छा नहीं आएगा या मेरा खराब आएगा. ऐसा नहीं सोचेंगे. Let's stay positive. The entire exercise that we are going to do today and tomorrow is going to be a learning experience to understand the perspective of the teachers on the kind of questions which were asked in the exam. So that is the entire idea behind the event. And I'm very happy to meet all of you who are today live, and we will be starting another 3-4 minutes. And I also want to take this opportunity to tell the students who are listening to me today that this exam is very uniquely placed chronologically, that between this exam and the INI-CT exam, you have a very small gap. Okay. So what will happen is, it is up to you. You may choose not to study for INI-CT, or you may choose to study for INI-CT, which will be actually a very smart thing to do because the gap is very less, and you might end up doing your PG in a central institute. So it's a very, very good chance to be taken. Second important consideration for all of us is, when we think about this exam this year, is that this exam today was delayed unexpectedly, massively. I think in the history of my career as an educator, I have never seen an exam delayed so much. And it was delayed because of the COVID pandemic. So that means the next exam that will happen in 2022 will not be so much delayed, because we had a massive pandemic going on at this stage, not in the next year stage. So the gap between this exam and the next NEET PG will be lesser. So that is why in DAMS we have now introduced special 6-month TND course, special 6-month regular course, because we understand that the gap between this exam and the NEET PG 2022 will be around 6 months. Another thing to notice is that after that, in January 2023, we are looking at the next exam, the much awaited national exit exam, the licentiate exam. And at that stage, the pattern will change. So we all have to now think that if you are an aspirant for NEET PG 2022 and you are joining us today, you are joining us to know how this year's paper was, so that you can take some hints about your exam when you reach to that stage. Okay. And second is, you also need to know that the next NEET PG 2022 will be the last exam in the current format. After that, the format will change. So if you are someone who has been in a I keep meeting students who are either in service candidates, who are in a job, who are thinking of an appropriate time to give the exam. 2022 will be the right time to give the exam, because then the pattern will change. So that is the idea that we have today. We have an idea that we are going to talk about NEET PG 2021. We will cover some subjects today from on the YouTube channel, and tomorrow at the same time we will come live on the YouTube channel and cover the rest of the subjects. And that is the entire idea. And I also want you to know that as far as I am concerned, I have reviewed the entire paper, and to me it looks like a moderate difficulty level paper. So I keep seeing students who are saying it was easy. I beg to differ, because although the topics were usual, in many questions the choices were close together, and it required thinking process to rule out the choices. So I would rate this paper to be moderate difficulty level. But the good thing is that 100% of the questions were from your DAMS class notes, and I'm very proud to say that we have record 100% strike rate in this year's exam. And we have been doing it for last 21 years, and I'm really, really proud of it. And with this, I'll ask, I see most of the students have now joined us. We are at 9:30 sharp. So I think we'll start with PSM first. What do you say, Dr. Siddharth Mishra? What do you think?
All okay, sir.
So let's start with PSM followed by anatomy. And I will request the teachers to, keep it short, crisp, question, possible answer, reason, so that, we can cover a lot of ground today. I wish you all the best to all the candidates. Again, I will repeat to all the candidates, do not use this session to create anxiety onto yourself. सब जो प्रिडिक्टर ये सब चल रहा है सब हटाओ. पेपर हो चुका है, रैंक सील हो चुकी है, ये सिर्फ एक लर्निंग एक्टिविटी हम कर रहे हैं. ऐसा ना हो कि आप उसके बाद बहुत घबरा जाएं कि मेरे तो इतने गलत हो गए. सबके गलत हुए होंगे, घबराएं नहीं. वी आर विद यू टू सपोर्ट यू, बट दैट इज वन रीजन व्हाई वी डिलेड दिस सेशन बाय 2-3 days, so that we don't induce any acute anxiety in you after the exam. So we thought we will do it after you have settled down. Consider this as a learning opportunity rather than as an analytical opportunity or speculative. Don't go into speculations. बिकॉज कभी कभी क्या होता है, मैंने ऐसे बच्चे देखे जिनके बाद में अच्छी रैंक आ रही होती है, उससे पहले ही वो स्पेकुलेट करके अपने ऊपर बहुत सारा प्रेशर डाल देते हैं. बहुत सारा प्रेशर नहीं डालेंगे, पेपर आप कर चुके हैं, एग्जाम हो चुका है, रैंक सील हो चुकी है. इट इज जस्ट academic exercise that we are doing to do better in the further exams. Don't forget to consider the upcoming INI CET in November as an opportunity. And do not forget, NEETPG 2022 will be the last NEETPG in the current format. After that, we will have the next exam. So these should be the factors to consider when you make a strategy here onwards. Another thing I wanted to say before I hand over to Siddharth is that, I see a lot of queries about students asking which branch they can get at what score and all that. Don't worry, we will cover that all in a separate career counseling session after the results. We will cover every specialty pros and cons, and we will definitely guide you about how to join which institute. We'll talk about all that once we have reached to the stage of the rank. I keep meeting students every day who say, sir, अगर मेरे इतने करेक्ट हो रहे हैं तो मुझे क्या इंदौर में रेडियोलॉजी मिलेगा, क्या वहां पे सर्जरी मिलेगा? मैं कह रहा हूँ अभी रुक जाते हैं, अभी we will cross the bridge when we reach there. हवा में ही हम सब कुछ स्पेकुलेशंस के अंदर नहीं क्रॉस कर पाएंगे, वहां पहुंचेंगे हम, वहां पे फिर मदद करेंगे. On this note, I'll invite Dr. Siddharth Mishra to start with the PSM section from NEET PG 2021.
Okay, so good evening, all of you. So I will be taking the first session, PSM. So this was a very tough year probably for all of us, because we were all down with COVID and thinking of a lot of questions coming from COVID, but it was a googly in the exam, because we hardly could see COVID, and that is where PSM played a major role, because roughly 19 questions were put into this slot. The questions were easy, trust me, it was easy, and it was more like a common sense question. Yes, it was not a traditional paper, because again, programs and statistics, the most important part of PSM was missed, but still, if you look into the paper, out of the 19 questions, I expect 16 or 17 you would have got right. See, even if I would have given the exam, or any other teacher in PSM would have given the exam, none would have got 19 correct. So let's smile it off for few questions. Okay, so this is a distribution of questions where you can see that infectious disease and environment were given the maximum load in this time sessions. Okay, the first question was from the chapter 2, health and disease, global hunger index, which is not included in. Now see, for global hunger index, the simple rule we should remember is rule of 5. Anything related to 5, child mortality under 5 and wasting in under 5. So all the options gone, you were left with only option number 2, that was infant mortality rate. This is typically seen in EQLI. End of the story. Yes. Now coming to the second question, which was from epidemiology. Now this was probably the best question, which would differentiate between the different ranks. Now over here, the question recall is still an issue, where they have basically given some CRP values. They have given the relative risk, and they made a table where they said that in the remaining 3 groups, the CRP values is going up and the relative risk is also going up. And let us make it very, very clear. A relative risk of 1 means no association. We know this. And that is the reason the best option which comes up over here is option number 2, no correlation between CRP and stroke at a value of 1. Okay, so basically this seems to be the best option as per the recall. CRP increases, reduces the risk of stroke. No, it will increase the risk of stroke. If higher CRP values were related to higher percentage, then it is a positive correlation. Yes. Women having CRP less than 4.9 had more chance of having a stroke. Absolutely not. More CRP, more is a stroke. So as per the options recall, option number 2 seems to be the best option. Okay, this was the main question which will differentiate the ranks of students, because the others were more of a one-liners. Now, moving on to the next chapter, infectious disease. 4 questions were there. They were all from vaccines, and technically they were all very easy. History of HIV in adult, which vaccine is not given? Now, in a person with HIV, we do not give a live attenuated vaccine, full stop, except yellow fever, cholera, and OPV when we have to travel, or if there is an outbreak, or rabies if there is a dog bite. So if you look into the option, only MMR or measles was the live attenuated vaccine. So that is a single vaccine I would not give. End of the story. Second question. Question was a child of 3 months old with history of yeast infection with repeated respiratory illness. Which vaccine to be avoided? And this was a typical question from the National Immunization Schedule. Now, BCG is given at birth. End of the story. M or MMR is given at 9 months. So we are left with only 2 options. Option number 1, DPT, and option number 4, IPV. Now, you know, whenever we give DPT, there is fever to the child. And that is the main reason we would not give DPT. ऐसे ही बेचारे को respiratory illness है. So DPT would have been the best answer as compared to IPV. IPV does not have any major side effects. So you can give an IPV. That's not a big deal. Okay. Now, in school, which vaccine is given to a 5-year-old? Now, again, a question from National Immunization Schedule. At a 5-year-old, we give DPT booster because typhoid and rabies are not a part of the National Immunization Schedule. End of the story. Measles, this is given at 9 months and 16 to 24 months. Yes? Okay. Now, encephalitis in Gorakhpur, which vaccine? JE vaccine, SA14142. Live attenuated vaccine, which is given subcutaneous. So answer to this question was option number 3. 4 questions from the vaccination, and 3 out of them were for the National Immunization Schedule. And that is the reason every time in the class, whenever we tell you, we always say, do not read IAP, read NIS. That's what they had asked probably from programs. So someone who was framing questions, they picked up vaccination to ask questions from the programs. Yes? Okay. Coming to the chapter 9, preventive obstetrics and pediatrics, they had put in a child height for age less than -2 SD likely represents. Now remember, we always talk for weight for age chart, because under the program we have weight for age. Now when they talked about height, the option is very simple. When you talk about height, it is stunting, and stunting typically refers to chronic malnutrition. End of the story. Yes, so nothing more to do about this in this question. 6 months old child, 8 kg weight, picture of a growth chart was given. What has to be done? 6 months, 8 kg, absolutely normal. Rather, I'll say a fluffy golu molu baby. Yes, so assure that the mother that there was no malnutrition. Now, there are some students who are saying the age is different, the weight is different. If that changes, answer will be different. But if this was the age and this was the weight, answer will be no malnutrition. Bachcha ekdam normal hai, bhaiya zyada mat khilao. End of the story. Chapter number 10, nutrition. Excellent question was asked. Patient is from Chhattisgarh. Complaints of spasticity and motor paralysis. What history won't you take? Now, forget everything. When we teach acute flaccid paralysis, we tell you the causes of acute flaccid paralysis: polio, transverse myelitis, traumatic neuritis, and Guillain-Barré syndrome. Yes. Now they are saying spasticity, spastic. So can't be Guillain-Barré syndrome. Can't be polio. So history of vaccination gone. So in this way, you could have ruled out and you could have easily said it is history of food intake, and typically pointing to neurolathyrism, and is common in Madhya Pradesh. Chhattisgarh was a part of Madhya Pradesh. That is where the examiner want to slightly create a confusion, nothing more. Second question, there was a maize-rich diet and they had asked it is deficient in. So in a maize-rich diet, the deficiency is typically in niacin. Yes, it is typically niacin. Now, sociology, 2 questions, very much unexpected. Child was taught hand washing technique. Which type of learning is this? Now, let me make it clear. Hand washing is not a skill. So it is end of the story. It is not psychomotor. Now, 2, cognitive is knowledge, whereas affective is basically an attitude. Now, if in your option, in the question, if the option 1 was there, that was the best answer. Now, if there is no option 1, then the second best answer would have been effective. Okay, so it depends upon whatever option was there in the exam. Yes. Okay. In a case of a man-made malnutrition, in ecological factor, which is the most probable cause, low socioeconomic status, not the fall of a man. Yes. Weak public distribution system, again not. No mother or father will want their child to be lean and thin. So it is basically food habit, and that is the reason which has become the most common cause of man-made malnutrition as of now. They will eat from Domino's and McDonald's. Duble patle bache, they would not eat fruits. So basically, it is the food habits which drives a man-made malnutrition, whether it be over or under. Yes. Okay. Chapter number 12: Environment. Air quality index in Delhi on occasion of Diwali was 407. Their assessment is close your eyes. Delhi will always have severe. Okay. So again, the examiner didn't want you to know the AQI guidelines. The examiner just wanted to know whether you have a common understanding that Delhi में Diwali time पे बहुत pollution होता है. It is severe. End of the story. The following device is used to measure low air velocity. Typical repeated question. It is the Carter thermometer, which measures the cooling power of air and also the low air velocity. Fever with chills, hepatomegaly, and the vector they had asked. Yes. So it typically seems like a sandfly. Okay, again, slight query with the question. If slight changes, different answer would come up. But typically, sandfly vector typically produces this kind of disease. Yes, okay. SI unit of brightness of source of light. Trust me, I could not get this question right because I also don't remember it. I had to read it because I read it in physics. The answer to this is Lambert, because the brightness of light is given by Lambert. Factual question. Okay. Soil throat swabs. Yes, very simple. Why this was asked? Because in COVID, all of us were getting a throat and the nasal swabs. That is thrown in yellow. You have to burn it. There is nothing to recycle because anything you recycle goes to red. Anything which is sharp goes to white. Metallic body implants, glassware goes to blue. Chapter 14 from disaster. Expected question tha yaar. In Kerala, after flood, people complaining of fever, doxycycline prophylactic was given. Which would you prefer to distribute? Zinc phosphide. Never. Zinc phosphide kills rats, but it is the most toxic insecticide. Rat baad mein marega, insan pehle mar jayega. The best answer was Paris green. Now, why Paris green? It is a larvicidal. Now, see, there is a flood. So the water will stay stagnant after some days. Mosquito will lay its larva and there will be outbreak of mosquito-borne diseases. That is the reason Paris green is the best answer to it. Last question. Healthcare or community? Healthcare facilities provided in school is delivered at the level of, answer is PHC. Yes, so at the level of PHC and at the level of CHC, we are providing these services. Yes. So this was all about from my side. If you have any queries, please feel free to contact us on the DAMS Club or anywhere. We will always prefer to take your doubts on the DAMS Club. So all the best for your results. Remember, the exam is over. So there's no point in speculating. Okay, don't get into the probabilities of ranks by hearing here and there. Yes, so thank you. All the best. Bye-bye. Now I hand over to Sandeep sir, okay, who will take you through a journey of anatomy. Yes, so Sandeep sir, over to you.
A very good evening, everyone. Let me just share just a moment. Okay, so let's start. This was the question: structure injured in the submandibular gland excision, right? And these were the recalled choices, right? Among these choices, obvious answer here is the lingual nerve. And we know that submandibular gland is having the superficial part and the deep part, and with respect to this muscle, which is mylohyoid. And if we look at the anatomy part here, we can see that with respect to the duct, this lingual nerve is looping around it. This is very important anatomy, that lingual nerve loops around the duct. Okay, very nearby to this gland is also hypoglossal nerve. Okay, so these two nerves are definitely at high risk of getting injured. Okay, when you are dealing with the submandibular gland excision, right? So this nerve, that is glossopharyngeal nerve, is deep to the muscle. Which muscle? That is hyoglossus, between the hyoid and the tongue, between the hyo and the glossus, right? So if you look at the choices now, inferior alveolar nerve lives within the, it remains within the bone and it supplies the teeth from below. So that is kind of well protected. Lingual nerve must be the answer. Now the D choice, some students are recalling as facial, some are recalling as nerve to mylohyoid. So whatever, if the facial nerve itself, the trunk was not, will be injured. One branch may be injured. So best answer, of course, is the lingual nerve, right? And next, this question was given. Patient came to the emergency after multiple fractures in the humerus, and then the presentation was unable to flex the and supinate the forearm, and there is loss of sensation on the lateral aspect of the forearm also. So which nerve will be injured? You see, answer in this part is the musculocutaneous nerve, because musculocutaneous nerve supplies the muscles in the arm, that is BBC, biceps, brachialis, and the coracobrachialis. Okay. And then it becomes the cutaneous in the forearm, that is lateral cutaneous nerve of the forearm. So those are the territory. Accordingly, answer will be the musculocutaneous nerve, right? Now here, downward enlargement of the spleen is prevented by, this is a repeat question. Answer is the phrenicocholic ligament. Let me show you. This ligament is actually present between the, you see, the diaphragm and the colon. So that is why it is called as phrenicocholic ligament, and it supports the spleen from below. That is why it is called as sustentacular lineus. It is a support and it will not allow any enlargement of the spleen go this way. Okay. So this is a repeat question. It was asked earlier. Okay. And in this diagram, this is a very schematic diagram. You can see between the diaphragm and the colon, this is the phrenicocholic ligament and this is the spleen, right? It's supporting the spleen. I believe this should be clear. And next question, nerve damage when the shunt is placed using the great stiffness one. When you are dealing with the great stiffness, when this is a you see, regularly discussed in the class that great saphenous vein is accompanied with the saphenous nerve. Please understand this. And also the short saphenous vein is accompanied with the sural nerve. So this is important anatomy that we have to remember. And when you are dealing with some procedure being done with the you see saphenous vein, which nerve is at risk? So answer among these options will be saphenous nerve, which is accompanying nerve. Is that okay? Yes. Now, next part, this question. Now, this marking was there in the posterior pharyngeal wall, and this is recalled by the students that what is the nerve supply to the marked muscle. Now, I can tell you that if this was the recall and this was the marked muscle, let me tell you, muscles of the pharynx and muscles of the palate, by and large, they are supplied by the 10th nerve. If this was asked, then answer was 10th nerve. But if it was not asked, and if I asked like it was examined by the doctor, now if I change the language of the question, answer will change. So let me tell you the anatomy here. Palate and pharynx muscles are supplied by the 10th nerve, particularly this pharyngeal branch of the vagus nerve. So that 10th nerve will be the answer if this was the question, if this was the marking. But if I say oropharyngeal region, the palate region, if I ask about the afferent part, then of course it becomes the 9th nerve. So again, depending upon the language of the question, but if this is the recall and this was the marking, then answer is 10th. Next, aneurysm of which artery causes the visual defects by compressing the optic chiasma? Now, you see this particular thing is from the neuroanatomy part. You see, looking at the optic chiasma, which is very close to the anterior cerebral and anterior communicating. Particularly, it is close to the anterior communicating. So what will be the answer among these options? Anterior communicating will be the answer. Let me discuss the anatomy. Let me discuss the anatomy here. So here, what I can say that this is the anterior communicating artery. And if it gets, and like aneurysm is there, if the inferior aneurysm particularly is there, inferior projection, then it will be going to, you see, impact the optic chiasma. So this diagram, I think you can understand that this is the inferior projection from the aneurysm of anterior communicating artery. Okay. And other projections can also be there, but the inferior projection particularly is going to impact this part. And in this diagram, again, we can see that this is the anterior communicating artery giving different projections, and inferior projection will involve the optic chiasma. And if optic chiasma is compressed, it will lead to the, you see, bitemporal hemianopia. And this can also be seen because of the pituitary tumor. But then, of course, in the question, it was asking about the artery aneurysms, and answer will be anterior communicating artery, right? Next question was, a patient is admitted with the diagnosis of the meningitis, and you see some history was given. So lumbar puncture was done to evaluate which is the last layer to pierce. Now we know the, you see, our CSF is present where? In the subarachnoid space. So when you keep on, you see, piercing, where will you reach? After piercing the arachnoid, you will reach the subarachnoid space. So the last layer to be pierced will be arachnoid. But let me discuss the anatomy quickly. We can see here, these are the parts of the vertebrae. We can see the spinous process, we can see the transverse process, right? We can see the laminae, we can see the pedicle part, right? And here I can show you, this is the labeled thing, what we have already discussed. Now let me show you the ligaments. You know? So what we can see, these are the spinous process. In between the spinous process, we have interspinous ligament. Compare these two pictures, interspinous ligament, right? And now here you can see in this part, if you take a section and you remove the anterior segment, you see only the posterior part, that means the laminae. In between the laminae now, which ligament will be there? In between the laminae, we have ligamentum flavum, okay? And if you see this ligament here, that is anterior to the body. We will never reach there. It is just to give you the idea which is the ligament. This is anterior longitudinal ligament. And this one behind will be the posterior longitudinal ligament, right? So we are not reaching those levels. And of course, we can see that these are the structures which are going to be pierced, supraspinal ligament. Then in between the spinous, we have this part, interspinal ligament, then ligamentum flavum, which connects the laminae, and then you will pierce through the, you see, arachnoid part, and then you will reach definitely into CSM, right? So these are the layers. Now, this papilla was given and it was asked, what is this papilla? If this was there, then this will be circumvallate papilla. How to identify? We can see the crypts by the side of the papilla, and we can see the taste buds on the lateral wall. If these features are there, we will say this is circumvallate papilla. Okay, other papillae can be there. If this type of papillae are shown, these are the filiform papillae. These are the filiform papillae. They don't have the taste bud. They are covered by you see, the stratified squamous keratinized epithelium. So they don't have the you see, taste bud here. And if they are present in the rows, we say these are this foliate papillae. And in the fungiform papillae and the circumvallate papillae, you might get confused. But how to identify? Let me tell you. If circumvallate papillae is there, you will see the crypts by the side, and you will see the taste bud on the lateral aspect. That is the distinguishing feature. But in the fungiform papillae, you will see the vascular portion among the core will be reaching the tip. Because the vascular portion reaches the tip, that's why red dots are seen on the tongue. That is because of the fungiform papilla, right? This is how we identify. All right. All right. So what is the doubt? Fine, no? No, student, as I told that it can be ninth nerve if the afferent was asked. I told you, na? I told you that if the change that question, then answer will be changed. Okay. If marking you put on the soft palate and you ask about the gag reflex, the patient, the doctor was touching it and then there was a reflex, then afferent will be ninth nerve. Do you appreciate? But as I said that if you see that question, then answer will be 10th nerve. Again, it will depend on the language of the question. I have given you both answers. I don't know what was the real question. I am telling what the question has been recalled. But I have told both the things. Na? Now this test, which was recalled, that pen test was there, right?
डॉक्टर संदीप एक बार चैट भी देख लेना इसमें YouTube में.
सर चैट देखा है. Students, मैंने chat देख के I told that this is a live session. Students, what this test is, this is the pen test. And pen test we do for the abductor pollicis brevis, and abductor pollicis brevis is supplied by the median nerve, right? Median nerve in the palm. So the answer to this question will be B. Okay, now let me take you back to that particular question which you are saying. Just a moment. Let me take you back to that question. See, let me tell you here that let me talk about the gag. For the gag reflex, we have afferent and efferent. Afferent is the 9th nerve, efferent will be the 10th nerve. Okay, gag will be absent even if 9th is gone or the 10th is gone. If I say the marking is here, suppose I say the mark, as you are saying that marking was on the you see soft palate part, fine. Now if I am examining that part and gag is there, if I ask that gag is because of what, when I touch the gag is there, then I can take the answer 9th nerve because of the afferent pathway. But if I mark this muscle, which was sent by some students that this was the marked muscle, and marked muscle motor supply, then it is the 10th nerve. I don't know what was the language of the question, but I have given you the both. If this was the question, then 10th nerve. If this was the question, 9th nerve. Are you understanding? So according to the question, I have given you both the scenarios. Now it again, I don't know what was the real question. I hope you could understand the other questions, right? Fine. Okay. So that was all from my side. Okay. So thank you, everyone. Now, I think next, I think Sanjeev, sir.
Hi, students. Good evening. And just a minute, I'll share my screen with you guys. Yes. So pathology questions, yeah, there were quite a few, and what I was seeing was from many of the recalls, many of them have given wrong, and students have got a lot of confusion regarding the questions as well. So let me just start looking at yeah, so the first question I'm taking, so please tell me if there are few recall errors will always be there. So let us look at this. So the question was, I know now female history was given. A female software engineer presents to OPD with complaints of easy fatigue. Female was given, so it should be she here anyway. So, pardon my grammar. History of sitting in front of computer for 12 to 14 hours per day, and takes junk food and less fruits and veggies. So this was given. Vegetables were less, and fruits was also less. So this was given to you guys. So whenever this was given, so whether male female doesn't matter, don't worry about it. This was the keyword, fruits and vegetables are less. That was one keyword. And another is hemoglobin was 9, anemia is there, and MCV is 120. MCV is 120. So this is definitely a macrocytic anemia we are talking about. So if this is a macrocytic anemia, no fruits and veggies. So less fruits and veggies I have written. Okay, no fruits and veggies. That's all fine. Definitely the answer will be folic acid. It is not cyanocobalamin. Do not make cyanocobalamin or B12. The source is animal. We have discussed so many times animal source. The source will be animal food, like meat, and even dairy products can be source for this. So it is not cyanocobalamin. Of course the other two were straight away ruled out. That is not the case. So answer is, in this case, the answer is folic acid deficiency. Folic acid deficiency. So don't get disheartened. I've seen this. Many people have been itna sara ghuma laga ke logic. Okay, I'll just give you one important hint. I do not know whether this was given. So for how long history? Was history given around less than 5 years or 1 year, anything? So was history given? I just want to know for how long this patient has been eating junk food or whatever it is. If that was given, that will help us better. Anyway, diagnosis doesn't change with that. So remember, cyanocobalamin deficiency will only manifest after 5 years of stopping eating. Say suppose I stop eating B12 from today, I will not develop anemia in 1 year, 2 years. At least 2 is a minimum, we say, because your B12 stores last for very long. Okay. Yes. So answer to this is yes. So folic acid is the correct answer. It is not a cyanocobalamin. If they have given fruits and vegetables, that is the keyword that has been given. In fact, if they wanted to give cyanocobalamin, they would have given he's a pure vegetarian and he doesn't eat anything apart from the vegetarian diet. So yeah, so folate deficiency is the correct answer in this, right? Now, so let me look at next question. And again, I am seeing this lots of confusion regarding the error. So let me see. A patient presents with history of fatigue, weight loss, multiple infection. So whenever you are suspecting a multiple infection, weight loss will be any malignancy. Multiple infection most probably will be a bone marrow problem. Why? Because then other cells, including neutrophils, won't be produced. That is what I will expect here. History of exposure of benzene was given for 20 years. Benzene exposure only causes one thing, AML. So answer to this is blood cancer. I have seen many of them answering bladder. Wrong answer. Benzidine dyes cause bladder cancer. Bladder cancer will not present with multiple infection if this was given. Many people are now telling me, no, sir, it was benzidine and the bladder was the answer. No, it is unlikely to present with multiple infection. So if the patient is having multiple infection and fatigue, suggestive of a bone marrow problem. AML is the only thing that is caused by benzene. Benzene causes AML. Age, okay, so that will not make much difficulty. Okay, that will not make much. 5 years, not a problem. Skin, not a problem. So skin cancer, it doesn't cause. Benzene causes only one. Remember, that is your AML, blood cancer. It will cause. Yeah. So if it was benzidine, then definitely different answer, bladder. But however, I told you multiple infection, fatigue, weight loss suggests for me it is a bone marrow involvement was there, right? So next question, look at this. I think history was given this. Many people have got confused again. I do not know why. 60-year or some old age, elderly was given in this. Patient is having a mediastinal mass diagnosed with red cell aplasia. Red cell aplasia is there. What is, what is the most likely probable cause of aplasia? I think there was also transfusion, not responding to transfusion was also given. Yes. So that, anyway, that doesn't make much difference for me because the diagnosis has already been given. Red cell aplasia is there. It is a thymoma. Now, again, many people are telling, sir, 60-year thymoma, you are confusing one thing. What is that? That is, you are confusing a lymphoma of thymus, which occurs in peripubertal region. That is the ALL. Thymoma frequently occurs in 40 to 60 years of age group only. So this is your thymoma, thymic neoplasm. Thymoma is an epithelial tumor of thymus. If you remember the histology, there is epithelial tumor in the thymus, as well as there is what do you call it? The lymphocytes, the T lymphocytes. So lymphoma of thymus. So thymic lymphoma will be second decade of age, peripubertal. Thymic lymphoma will be peripubertal. Yeah, if benzene was there, then definitely there is no other way out. And I told you, anyway, if fatigue, multiple infection, etc. was given, I'm thinking of a bone marrow involvement there. Bone marrow involvement. Okay, but anyway, doesn't matter. Okay, multiple infection, frequent infection, anything we are going to suspect of that only. The next question, patient is having general fatigue was given, tiredness, then primary clinical examination, uneventful, normal TLC, DLC. All these things are not keywords here. Don't worry. No immature cells was given. Yes, this is a keyword. That means it is not a blast. There are no blasts. Superficial discrete lymph nodes were present. On biopsy, effaced architecture. So suggests of a lymphoma now, effacement of architecture. Indented nucleus, prominent nucleolus. The last was the most important keyword that was given. CD10 positive, BCL2 positive. CD10 is a germinal center marker. We have studied so many times in the class. Germinal center, it automatically rules out mycosis fungoids, and it can be other three still present. BCL2 is also positive. So again, it can be most likely follicular. That will be the answer here. I am ruling out Burkitt lymphoma because general examination is unremarkable. So it is other Burkitt lymphoma will not have an unremarkable general physical examination. Yes. So this was a straight away follicular lymphoma. And I'm sure all of you have got it correct. Next question. So in this, I want from you guys, okay. So this question was a 20-year-old boy presents with fever for 2 months. Little bit of problem with recall is there. I want you to clarify because that keyword is there. Two keywords are confusing here. And now has gum bleeding, I guess. That history was given. I do not know. Petechiae, easy bruise, skin blisters. Skin blisters, query, I am suspecting, query, infection in the skin. I'm suspecting infection. It is not petechiae now, infection in the skin. Fever is also there, which is also suggestive of infection for 2 months. Clinical examination. Now tell me this is correct or not. Some people told me there was hepatosplenomegaly. Some people told clinical examination is unremarkable except for pallor. So, okay, so there was a low-grade fever given. So if hepatosplenomegaly is not there, some people told me that the hepatosplenomegaly was not given, sir, and it is unremarkable clinical examination. So if clinical examination was unremarkable, then definitely hepatosplenomegaly is a keyword which is against aplastic anemia. That is why I am asking you this. Please confirm, was hepatosplenomegaly given or not? Because it's a keyword. If hepatosplenomegaly is there, I run away from aplastic anemia. So shows macrocytosis, I think, and aplastic anemia can show macrocytosis, especially because of in regenerating phase, because erythropoietin stimulus can sometimes. Reticount is low. Bone marrow shows fatty marrow or fatty streak. Something was given. So this definitely is suggestive of aplastic anemia. So yeah, so if this is not given, then well and good. Then for me, I am more happier to make a diagnosis of aplastic anemia. Only one thing with splenomegaly, I was not thinking. Yeah, so if there is a no hepatosplenomegaly, definitely, yeah. So idiopathic acquired aplastic anemia, that is what it will be. So most of the aplastic anemias will be the acquired ones will be idiopathic, will not be knowing the reason, but most likely immune mediated will be there. Yes, so idiopathic aplastic anemia, that is correct. So no problem, idiopathic aplastic anemia. That will be the correct answer for this then. Yes, so no hepatosplenomegaly, I'm very happy. So then definitely everything fits into this. So some people ask me, sir, hepatosplenomegaly was there, and then, you know, I start suspecting away from aplastic anemia. Anyway, it is not PNH, it is not MDS. So if hepatosplenomegaly was not there, I am now I'll start suspecting a little bit. If it was there, I would have thought of a atypical infiltration into myelophthisis. But hepatosplenomegaly was not given. So unremarkable, then that's the correct thing. Then answer will be aplastic anemia. Sixth one, this was an easy one. Everybody would have made it. All of the following are increased in iron deficiency anemia except. So which is not increased in iron deficiency anemia. So TIBC is increased in iron deficiency anemia. Transferrin saturation is reduced in iron deficiency anemia. Red cell porphyrin is increased. So either they have given red cell or serum or urine porphyrin, doesn't matter. It will increase in red cell. From red cell, it goes into the serum. From the serum, it will be excreted in urine. So it doesn't matter whether it was given serum, red cell, or whether it was given in urine, or it was not mentioned, only porphyrin was mentioned. That's also fine. Serum soluble transferrin receptor, this is also increased. We had discussed this in the class. This is the most specific test. Remember, it is the most specific test. So, you know, answer to this question, although it is more specific, we don't use it because it happens late. So answer is transferrin saturation. Transferrin saturation will be reduced. Next was this one. So this was a simple question. 35-year presents with weak upper limb pulses. So basically pulseless disease, retinal hemorrhages, visual disturbance was given. So just confirm with the options here, because I mean, where diagnosis very clear. We have made a diagnosis here. Absent upper limb pulses, I am suspecting, especially in a 35-year, Takayasu arteritis is my suspicion. Option B will be the correct answer. Did they give you a giant cell arteritis as an option? I do not know. Even if it was there, it is not the answer. Now, many people, sir, visual disturbances occur in giant cell arteritis. Yes, correct. But however, do not confuse. The age is the most important difference between these two. We have discussed this a number of times. It is not the pathogenesis. It is not the which artery is involved. It is the age that is the most important. Now, next question number 8. Try to, you know, try to tell me this. What was the question? Mutation seen in HNPCC, they have asked. So mutation is seen in which gene was asked, or what mutations happen was asked. Anyway, so if these were the option, of course, HNPCC will have mutations of MSH and MLH mutation. There was a question on MDS. Yeah, we have, no, not MDS. So MSH, MLH mutation, both of these genes are mismatch repair genes. So mutation will be in the mismatch repair mutation. Due to mismatch repair, there will be secondary. So very important, secondary. Do expect this question in subsequent exam. There will be a frame shift mutation happening. So there will be frame shift mutation happening secondarily to the mismatch repair defect. Mismatch repair defect means whatever extra nucleotides are there, they are not removed. Extra CG or ATCG repeats that might be there will not be removed, and that will be okay. The gene was asked, then it is a mismatch repair gene. So it is not a mutation. So it is a mismatch repair gene. MSH and MLH are the genes that are there. Okay, yeah. So MDS question mein only anemia, all lineages were not decreasing. Rohan Rajput, can you please try to recollect the question? Don't tell me MDS wala question, because then you are getting yourself 16-month child. Which one was a 16-month child? 16-month child kaun sa tha? 16-month child for HNPCC? Doesn't matter. Yeah, HNPCC, whether 16-month or you are making in 10-year, mutation doesn't change, isn't it? Yeah. Merit will okay. So now next question, look at this. This again we have discussed it in our integrated cardiac class for this year. Last year also we had discussed this. This was a simple one. 34-year-old woman, age is not important. Fever, migratory arthritis of the lower large joints was given. Tachycardia was also given. Pansystolic murmur, echo shows mitral regurgitation, biopsy. What is this showing? This is your Eschhoff nodule that you are seeing here. Yes, so this is your Eschhoff nodule. Yeah, megakaryocytosis was not given. I think it was megakaryocytes are absent was given. Megakaryocytosis is unlikely to be in aplastic anemia. Okay, yes, this is your Eschhoff. That is the correct answer here. Next one, a simple question again. So this was the dead easy question, I guess. 10-year child, whatever is the age, 10-year is slightly unlikely for this case. But anyway, I got 10-year as a recollection from students. Presents with generalized edema. Cholesterol is increased. Urinary protein 3+. Urine microscopy shows oval fat bodies. These oval fat bodies are nothing but your fatty cast, or the fat is there. Lipiduria is happening. And yes, this is your nephrotic syndrome. So there is no second thought about this question. Yes, patient presents with cirrhosis. Patient presents with cirrhosis. This question, in fact, one of the students sent me exactly same question from our DKB, and that student had asked me for explanation, and also it was asked even in the club as well. So cirrhosis is there. I think alcohol history was given, I guess. Yes, and liver biopsy shows eosinophilic material inside the cell, which is cytokeratin positive. What is it composed of? Basically, cirrhosis eosinophilic material is your Mallory-Hyaline or Mallory-Denk bodies, and Mallory-Hyaline are keratin intermediate filaments. Keratin intermediate filament. So intermediate filaments should have been given. I do not know, because this is the recall. Only somebody has given me composed of intermediate. It should be intermediate filaments. Yes, intermediate filaments should have been the answer. So that will be the correct answer. Keratin intermediate filaments. IF is intermediate filament here. Next question. Yeah. So again, many people have lots of controversies created out of this. Let me look at this. A 50-year-old male presents with fatigability, easy fatigability for 1 year. So slow onset, mild anemia, massive splenomegaly has been given. So massive splenomegaly is a keyword. Hemoglobin 10. I think TLC was 1.2 lakhs. I guess TLC was 1.2 lakhs. Platelet count, I do not know. Some people told 50,000, some people told 5 lakhs. I do not know. Anyway, it doesn't matter. Both of them will end up making a myeloproliferative neoplasm. Whether it was 50K or whether it was 5 lakh or 5K, doesn't matter, because cytosis, one cytosis is already present. I'm suspecting a myeloproliferative neoplasm. And another keyword, basophil, was given as 4%. Basophil is a 4%. So I'm suspecting now query CML because of this basophilia. Query I'm still writing because CML diagnosis is done by genetics. Correct? Yes, genetics. So most specific or most sensitive or next line of investigation, doesn't matter. Next line, most specific, most sensitive, doesn't matter. I would have done a genetic analysis. I will go with fish if that was in the option. I think fish and PCR both were given, I guess. Yes. So yeah, sensitive was asked, doesn't matter. I told you, next investigation, specific investigation, sensitive investigation, I will always go with fish. Single best answer, I would have gone with fish. So I think option fish and PCR, both of them were given. So I will go with both. I mean, that will be the correct answer. It is not immunophenotyping. Somebody said flow cytometry. That is also not the case. Whole body PET CT is not the case. Lab score is also not the case. Although lab score, yes, lab score is in CML, it will be reduced, but it is not a diagnostic. So that's why do not do that. So yes. Next one is a 21-year female pap smear with hyperchromatic nuclei, pleomorphism, low maturation index, and almost having all thickness. Low maturation index involving almost the full thickness. So I do not know whether it was pap smear given or not, because hyperchromasia, polychrom, and full thickness, because it is very difficult to comment on full thickness in pap smear. Doesn't matter. This the description, microscopic description, hyperchromasia, pleomorphism. If it was a carcinoma, then I will call it as an anaplasia feature. If it is not a carcinoma, it is just in the epithelium, it will be a dysplasia. So answer is this will be a dysplasia here. So again, do not confuse. Anaplasia is the next level of dysplasia. Hyperchromasia, pleomorphism, all these can be seen even in anaplasia. If it was a carcinoma, then I would have made it as an anaplasia. Anyway, that was not the option. It is not a carcinoma because there is no invasion given to us. It is not a metaplasia because in metaplasia, there will be no hyperchromasia, nuclear pleomorphism happening. Cell will change. It is not hyperplasia because number of cells will increase there. Right? Yes. So next question, poor prognostic factor in multiple myeloma. One-liner question was there. Answer to this is beta-2 microglobulin. So increased beta-2 microglobulin is one of the poor prognostic features. Creatinine is used for a diagnosis because in CRAB criteria, renal failure is there. Calcium is also used for a diagnostic purpose. M protein is not used for a diagnostic, and it also doesn't help in poor prognosis, because if M protein is elevated, the prognosis is better because M protein is protective, by the way, right? Yes. So this was then next question. 6-year-old boy was given history, I guess, and white reflex on eye examination was given. Biopsy shows a flexner Wintersteiner rosettes was given. So I'm not very clear about the options what were there. So medulloblastoma, retinoblastoma, rhabdomyosarcoma, and optic nerve glioma is what I've got. Answer to this is straightforward. Flexner Wintersteiner rosette. Forget about that. Most important is eye examination and a rosette. So tumor of orbit, rosette, retinoblastoma will be the answer. Medulloblastoma occurs in the cerebellum. Rhabdomyosarcoma can occur in the periorbital, but it will not show rosette. Rhabdomyosarcoma will show the tadpole cells or the strap cells, and optic nerve glioma will show, can occur in the retroorbital region, and that will show your Rosenthal fibers. So these were the question. I hope. Why not carcinoma? Somebody is asking why not carcinoma in this, because no invasion has been given. So if you are talking about no invasion was given in the history, that's why it is not a carcinoma here. No invasion was given. That's why it is not a carcinoma. Anything? Yes. I've missed out. Did I miss out on anything? If anybody, yeah, but biopsy and PAP both were given. Okay, so that's what. Anyway, description was for a dysplasia there, right? Dysplasia was there. Inflammatory cells are absent for what? Yeah, so if, okay, somebody is talking in this, inflammatory cells are absent, you have given, very important. So for further, I will tell you, inflammatory cells will be present if it is a carcinoma. On a pap smear, how do we identify if it is invasion has happened? Because when invasion happens, there will be death of the cells happening. Death of the cells will lead to inflammation. So on pap smear, if you find, the HCl features, that is SYN3 or HCl features, and if inflammation is present, we think of a carcinoma. So very important is hyperchromatic nuclei, pleomorphism. Inflammation was absent is in favor. It is not a carcinoma. If inflammation was present, then I would have thought of a carcinoma if inflammation was present. What was the question on IBD? Please, can you tell me what was the question on IBD? Black lymph node. Somebody is telling black lymph node, lung cancer, black lymph node question. What was the question? Can you please tell me? I didn't get that. And Gleason's 6 criteria was asked. Gleason's 6. What was the exact question? I have discussed Gleason's criteria in detail in DVT also. Please tell me what was the question on Gleason 6. Okay, Gleason's score 6 was there. PSA was 8. So what is it? Prognosis will be good basically. So it will be new Gleason's grade group 1. 6 will be grade group 1. Prognosis is good. Lung cancer with black lymph node, what is the cause? Okay, patient was having, so was it mentioned lung cancer or was it not mentioned anything? So lung cancer with black pigment, it can be anthracotic pigment. Yeah, that will be the case. Just to make sure skin lesions were not given, because melanin also can be, black in color, because lung smokers will cause lung carcinoma. That will be black colored pigment. Next step for Gleason's 6. That will be discussed to you in urology, don't worry. No, benzidine dye was not there. Benzene was there. 85-year man, Gleason's, what will you do next? Yeah, that is a surgery question. Urology will discuss. Lung cancer, 85-year-old. Okay, so let me just add that question as well then. So lung carcinoma, 85-year-old, and black colored pigment, and this has to be now carbon. Carbon will be the pigment. Another black will be melanin. I hope there was no skin lesion given, because melanoma can metastasize. Okay, reason would be carbon then. Now, SCC as such doesn't have pigment. So, squamous cell carcinoma occurs in smokers, and smokers will have anthracotic pigment in them. That will be the answer. So carbon, because smokers will have anthracotic pigment. Anything else I missed out? Somebody, I just missed out one more question. What was that? Just a minute. Yeah, so I think we are done with all the questions here. Yeah, so what was the question on IBD? Somebody said some question was there on IBD. Please, can you help me out with that IBD question? I missed it out somehow, or maybe it will be recalled. IBD, what was the question on IBD? Just please, if you can quickly tell me. There was a bladder carcinoma or a melanchoplakia. Image was given. Image was given. Okay, image-based question. Sorry, there was one image-based question. Huh? Okay, melanchoplakia or bladder question. Okay, so I have to check with that now. What was the image? I'll just put it in the club and confirm with you guys what was the question. Okay, yeah. So I think this is what is my share of the questions here. Yes, so I hope all of you have got most of the questions correct. They were really very easy question. All that you required was a simple, basic common sense application of your knowledge from your notes. So I think I'll now invite next to Dr. Thiru, sir.
Yes, sir. Okay, sir. I'll share my screen, sir. Hello, very good evening, doctors. How are you? I think pharmacology question was very, very easy, I think. What about your opinion? Very good evening, very good evening. Okay, how do you feel pharmacology question? Is easy or not easy? Very easy. Wow, very good. Very easy, tricky, not easy, very easy, tricky. Okay. Right, shall we go for discussion? Ready? So what are question recalled for students? I arrange in the order that is from general pharmacology and up to anti-cancer ocular pharmacology, like that. Okay. So first question, a pregnant female was taking indomethacin thrice daily till 35 weeks of gestation. Which anomaly would be expected in the baby if delivered now? Okay. Can you please answer this question? Actually, the pregnant lady who was on indomethacin up to 35 weeks. If she delivered baby at this week, what happened? See, indomethacin, we know NSAID, the two non-selective COX inhibitor that will cause premature closure of ductus arteriosus. Very good. All you have done, very good job. Answer B is the right answer. Very good. And we discussed in the class, indomethacin, NSAID, useful for medical closure of ductus arteriosus. So it will resulting in premature closure. Very good, very good. All are doing very good job. Okay. Lithium is the one going to cause Epstein anomaly. Good. So first question, you have done a very good job. Now, Which of the following formula useful for calculating dosing rates? Very simple. Dosing rate means simply called maintenance dose. If we say dose, maintenance dose, the formula for maintenance dose equal to, if we know clearance value, we can make it the formula for maintenance dose. Maintenance dose equal to clearance multiplied by target plasma concentration. For example, we discussed in the class, clearance equal to rate of elimination divided by plasma concentration. So maintenance dose equal to clearance multiplied by target plasma concentration. Okay, good. You mentioned answer B is a very good answer. Good. Next, very, very simple, straight question. Very question. Beta 2 receptor acting via. What is the answer you told? Beta 2 receptor. Beta, all the beta 1, beta 2, beta 3, all beta 1, 2, 3, all are G protein coupled receptor. That means acting via GS pathway, G stimulatory adenyl cyclase pathway. That means answer is option number. Come on, what is the answer? Option is option number A, adenyl cyclase pathway. Very good, very good. So question, we discuss G protein coupled mean acting via two-way, either adenyl cyclase or phospholipase C. When you say adenyl cyclase, all the beta receptor, either beta 1, beta 2, beta 3, all are acting as a GS. So answer right. You've done a good job. Good job. Okay, good. Next, some recall question from a CVS paper. Look at this. A 36-week pregnant patient on warfarin, INR level is 3. Best course of action would be, what answer? What answer you made for this question? Patient is 36 week of pregnancy. INR is 3. What is the best course of treatment for this? Okay. Add aspirin, aspirin the heparin, continue warfarin, stop warfarin, switch to heparin. What the answer you told? Come on, I'm waiting. Yes, good. Answer D. Stop warfarin, go to heparin. Good, good. You've done a very good job. Look here. Warfarin is a teratogen causing Conradi syndrome, unsafe in pregnancy. Okay, so we discussed this in class. Better go for heparin or LMWH. Okay, and we have some guidelines. According to American Heart Association guidelines, up to 13 weeks of pregnancy, that is first trimester mean, go for LMWH or heparin. Whereas warfarin can be used in second trimester, that is 13 to 35 or beginning of 36. But again, the 36 week, when at the 36th week, again you should go for heparin. So heparin. So answer, you are right answer. So no problem at all. You've done a good job. So for this question, answer is heparin. Good. A patient with atrial fibrillation was on digoxin. He was started on KCL, triamcinolone, clarithromycin, aspirin, and the serum level of digoxin was 2.5 and is increased to 3.4. Which of the following drug responsible for increase in concentration of digoxin? Whether the state questions come like this or not, I don't know. But the concept here is whether the question is same stem or not, I don't know. But this student given the question. The concept, what you should note here is the digoxin level is increased by what? That's one. Options are triamcinolone, KCL, aspirin, clarithromycin. Very simple question. Look here. Yes, answer D. Very good, very good. Clarithromycin is a macrolide group of antibiotic having microsomal enzyme inhibitory property. Okay. Spirit ghost pre-glycoprotein blocker. No. Here the concept is macrolide. It's a macrolide. Macrolide going to have microsomal enzyme inhibitory property, thereby elevating digoxin level. Whereas we have something called verapamil or quinidine or amiodarone. They are the one having P-glycoprotein blocking property, thereby they will increase the digoxin. Okay. And one more doubt the students asking regarding potassium. Look here. What Goodman-Gilman says, hypokalemia, hypomagnesemia, and hypercalcemia will aggravate digoxin toxicity. That is because this will increases the digoxin affinity towards sodium, potassium, ATPase. So they're going to aggravate. Okay. So now the question is, this question mainly based on microsomal enzyme inhibitory. If the P is given me, the verapamil, quinidine, amitriptyline. Clarithromycin is a microsomal enzyme inhibitor. Okay. Next. So you should know, I think enzyme inducer, inhibitor, you know. Now look at this. Wait. A patient with easy changes of MI underwent coronary artery bypass grafting. What drug should be added in the list along with the aspirin? Can you please answer? What the answer you made for this question? Okay. What is the answer for this question? Patient had MI, undergone coronary artery bypass grafting, and he was put on aspirin. Along with that, what can be used? A is good. A is good, man. Ganguly, option number C. P2 white blocker. Good, good. All are doing very good job, man. It's a clopidogrel. Clopidogrel. See, we discussed in our class for treating a MI patient in ST MI, we give painkiller like morphine or NTG, and we also know that opiates, some opiates are contraindicated, like pethidine, Preventives not given. But straight to your question, here we should give antiplatelets and also plan for thrombolysis and for angioplasty. Only one point, non-essential mean no need of thrombolysis. But the question was, when a patient undergone angioplasty or undergone CAPG mean, even after CAPG, even after angioplasty, the patient should be put on dual antiplatelet. This is your NEETPG question, a straight question from Goodman-Gilman. Even after undergone angioplasty, even after undergoing CAPG, the patient should be put on dual antiplatelet. For example, aspirin plus P2 white blocker like clopidogrel. This is a question for you. So all have done a very good job. Good. Right. Yeah, women used aspirin for arthritis, and she developed intestinal bleeding, which occurred due to infusion of what? I think it's very simple question. Can you please answer for this question? A woman used aspirin for treating arthritis. Following this therapy, developed intestinal bleeding. What is the reason for this? See, aspirin, you know, having antiplatelet activity. Aspirin having antiplatelet action is due to inhibition of thromboxane A2 synthesis. So answer is option A. Very good, very good. All are doing a very good job. Okay, good. So we studied the class aspirin, low dose aspirin, selectively, irreversibly inhibiting COX-1 enzyme, thereby inhibiting thromboxane A2 synthesis. That's why having antiplatelet action, thereby causing bleeding problem. This we discussed in the class. Okay, and I'm not able to recreate the question, but the question somebody told, there is a question on which antihypertensive causes angioedema, like the question. If that's a question, main answer is AIIMS. So question, which is the antihypertensive causing angioedema? Mean answer ACE inhibitor. But I'm not getting the exact question. If it is due to antihypertensive mean ACE that is due to accumulation of bradykinin, that can be treated by icatibant. Icatibant is a bradykinin antagonist. Okay. Yes, ACE. Yes, good. If it means ACE. But you should know there's one thing called hereditary angioedema due to C1 esterase enzyme blocker that can be treated by Ruconest or Kallikrein blocker or Danazep. Since you are telling lisinopril is given option, lisinopril is the ACE inhibitor, so that's the one causing angioedema. Good. You are done a good job. Good. And there's also one more question. I'm not getting exact answer. Nitric oxide synthesized from where? What is source? What is source of nitric oxide? If this is the question, main answer will be arginine. So what Goodman-Gilman says, look here, we have one thing called arginine. From the arginine, with the help of nitric oxide synthetase, there's a release of nitric oxide. So it's a biochemistry question as well as pharmacology question. Nitric oxide synthesized from L-arginine. Source is L. No such question. Leave it. Somebody posted me. No, leave it. No problem. No problem. No problem. Next. There's another question posted by somebody. A women on antihypertensive who wish to conceive, which medicine should be stopped, or which medicine should not be wrong? Recall me. No problem, doctor. No problem. Say antihypertensive absolutely. Antihypertensive absolutely unsafe in pregnancy, mean again ACE inhibitor or ARB. If it is there, this answer. If wrong, I mean no problem. Okay, right. Next, analgesic drug in renal failure and patient on dialysis. What answer? This question is there. Mean, can you please answer? Analgesic drug that can be useful in a patient with renal failure and used on dialysis. Mean answer. See, indomethacin, naproxen, diclofenac, all these drugs are purely non-selective COX blocker. They cause nephrotoxicity. Whereas acetaminophen is a paracetamol. Paracetamol, it's mainly COX-3 blocker. This don't cause problem of kidney problem. So answer D. Yes, you are marked a good answer. Very good. So whereas the non-selective COX blocker, they blocking COX-1 enzyme in the kidney, thereby reducing the renal blood flow, thereby causing problem. Whereas paracetamol do not cause this problem. Okay. Drug of choice for hypertension. This is aliscarin, doctor. Aliscarin. And your friend is asking answer nicely. Aliscarin. Okay. Now, some CNS question recalled a patient presented with the vomiting and was treated with an anti-emetic agent. Later, the patient presented the abnormal movement and posture. The following agent to be used to counter the problem. Can you please answer this question? A patient had vomiting. For vomiting, he was given some anti-emetic therapy. Following anti-emetic therapy, he developed the abnormal movement posture. What answer? Yes, very good. Answer is option A, benzhexol. See, anti-emetic may be metoclopramide. That's a D2 blocker crossing the blood-brain barrier, causing EPS, extrapyramidal side effect. For this, we're using benzhexol, the so-called trihexyphenidyl, a centrally acting anticholinergic. Very good, very good. Okay, so for treating a D2 blocker induced EPS, the centrally acting anticholinergic is a drug of choice. For example, trihexyphenidyl, or we can use benzatropine, biperidone, procyclidine, like that. So in your paper, this was the given option. So you are done a very good job. Good. Of course, we study in the class what are the other type of EPS and treatment and all we discussed in our regular class. And also I made a video of all the questions beautifully with extra points. 1 hour and 25 to 1 hour 30 minutes video. All the recalled question I framed such a way in a good background and good slides. So you can go through that. Now just to see the answer for the question alone. A patient received halothane and developed increased body temperature, muscle rigidity. Administration of which of following drug can increase the risk of present condition? Can you please answer? Come on. Patient on halothane developed body severe temperature rigidity. It's a case of malignant hyperthermia. Administration of which of following drug can increases the risk of this condition? Okay, the increased risk is due to very good answer number C, succinylcholine. Not A, man, somebody confusing here. Dandrolin is useful for treating malignant hyperthermia, whereas here which of the following drug can increase risk? Mean answer succinylcholine. Succinylcholine is the depolarizing skeletal muscle relaxant. This will cause malignant hyperthermia, whereas dandrolin useful for treating malignant hyperthermia. So remember, succinylcholine causing hyperthermia in a people with the ryanodine receptor abnormality. It's because of pharmacogenomic type of adverse drug reaction. So this will be discussed by anesthetists. Don't worry. See, among the anesthetic agent, most commonly hyperthermia caused by succinylcholine. A local anesthetic causing hyperthermia, think of lignocaine, whereas inhalational GA causing hyperthermia, think of halothane, like that. So anyway, dandrolin useful for treating hyperthermia. Don't mistake this. Okay. Atropine. Come on, Dipsana is asking atropine. Atropine also increases body temperature, but not going to cause muscle rigidity. So increasing rigidity, increasing body temperature, a pathognomonic hyperthermia that is most commonly caused by succinylcholine rather than by atropine. Okay, Dipsana bista. Okay. Next, a recall question for endo. I think only one question I was able to recall. I don't know why. Tyrosine kinase action. Okay. See, insulin is the answer. Insulin, a drug acting on tyrosine kinase enzyme linked receptor. For example, look here. A receptor in the cell membrane connected with the enzyme called tyrosine kinase, which is the endocrine hormone acting on not there mean insulin acting on enzyme linked receptors. Okay. Next. This question. I think there's a question on paronychia, nail bed infection. This is question, but nobody tell exact question. Anyway, if the question is on paronychia, mean remember for paronychia, best options are either we can go for amoxicillin, or we can go for cloxacillin, or we can go for clindamycin. These are best option. So, but in your question, the paronychia in the option, they go norflux, metronidazole, co-amoxiclav, amikacin. What is the answer? Yes, it's co-amoxiclav, amoxicillin with the clavulanic acid. Very good, very good, very good. Next, a patient on anti-lepra drug therapy present with the redness and also tenderness on pre-existing lesion, treatment would be very simple question. Look here, patient having leprosy on anti-lepra drug therapy. Following drug therapy, the pre-existing lesion get improved. Getting tender and pain. What is the answer? See, actually, it's a case of type 1 lepra reaction. Type 1 lepra reaction. For this case, continue anti-leprosy drug therapy and also start steroid. This answer. Continue. Okay, good. Majority voting for option B. Very good, very good, very good. So, type 1 lepra reaction means cell mediated immune reaction. For that, best is adding steroid. No need to stop anti-lepra therapy. Whereas for type 2, that systemic involvement, for that thalidomide. Thalidomide not useful for first type 1 reaction. Okay. Next, a patient on metronidazole, co-administration of which are following to be avoided. Okay, patient on metronidazole, co-administration of which are following to be avoided. Very simple state question. Can you please answer? I'm waiting for your answer. Option number patient on metronidazole, which drug should? The answer is alcohol. Very good. In alcoholic people, when they give metronidazole, risk of disulfiram-like reaction. Risk of disulfiram. And we also discuss what are the important drug causing disulfiram-like reaction. Further, we discuss CM Priced GT Naidu, a scientist, Chief Minister, Priced GT Naidu, chlorpromide, savurazone, metronidazole. Metronidazole was in your question. That when given to alcoholic people, risk of disulfiram-like reaction. And a pregnant female with 36 weeks age gestation have tender vesicle around the vulva. Treatment done with, look him, a pregnant lady with a tender vesicular lesion around the vulva. What should be done for this case? Give acyclovir and plan for elective C-section. Give acyclovir, wait for spontaneous delivery. Give acyclovir and do labor induction labor. What is the answer? The answer is give acyclovir and plan for elective C-section. Very good. All are good. Very good answer. You have done a very good job putting right answer. It's a case of herpes. Whenever there's a tender herpes vulval infection, mean don't allow the normal birth. Go for cesarean section. Okay. Next. This question, I don't know whether came or not. Somebody told sulfonamide and porphyria. Whether this somebody says in my recall, somebody says no, somebody yes. I don't know. But the question is, which drug may cause risk of acute intermittent porphyria? For that, you should know drug causing porphyria mean, remember, sulfonamide may cause porphyria. Other drug causing porphyria mean phenytoin, rifampicin, ocipil, bobshits. No problem, no problem. Somebody mistakenly given this question. And a woman on oral contraceptive pill later developed TB, for which she was given anti-TB drug. This is a very, very, very straight question. Can you please answer this question? Come on, come on, come on. A patient on OC pill given ATT, and she was advised to use additional contraceptive method because what? Because of what? No problem, doctor. Now listen to the question. Patient was on OC pill, developed TB, and was given additional. Yes, good. This is due to rifampicin is a microsphere, inducer causing OCP failure. Thereby, she was advised to go for extra method of contraception. Very good. All are doing very good job. Good. Next. Mitomycin C topically can be useful for what? Option given: subclottic stenosis, type 1 lymphoma. Mitomycin C, anti-cancer drug useful for urinary bladder cancer. This drug can be topically useful for treatment of laryngotracheal stenosis, the so-called subclottic stenosis. Yes, everybody doing a very good job. You are putting answer, right answer. Good, good, good. And we discussed in the class the mitomycin C useful for intravesically for treatment of bladder cancer, and also useful topically for treatment of laryngeal stenosis, and also for esophageal stenosis and to prevent post-synechial. Okay, and this action is because of it has anti-fibroblast activity, like that we discussed in the class. Now, another very straightforward question, simple question. Methotrexate mechanism action in the treatment of osteosarcoma. Look here, methotrexate, we know antifolate drug. The antifolate drugs mean the anti-metabolite. This drug acting by inhibiting what? Can you please answer? Come on, come on, come on. I want answer is acting by inhibiting dihydrofolate reductase enzyme. Good, 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 good. So look here, methotrexate actually actively enter into cancer cell where it become active form methotrexate polyglutamate that going to inhibit dihydrofolate reductase, thereby inhibiting folic acid synthesis, thereby acting on S phase of cell cycle. That's what discussed. And somebody mentioning the question, tocilizumab works by blocking what? Interleukin 2, IL-1, IL-6, IL-8. What the answer? Tocilizumab acting by inhibiting what? The right answer is answer interleukin 6. Somebody posted like this, and somebody posted like this also. Which are the following may be acting by inhibiting IL-6, like that? I don't know. But the question is regarding tocilizumab. Remember, tocilizumab, a drug acting by blocking interleukin 6. Okay. Now, rituximab means CD20, infliximab means TNF alpha blocker, bortezomib means proteasome inhibitor. It's a proteasome inhibitor useful for multiple myeloma. Anyway, the question is tocilizumab means interleukin 6 inhibitor. Okay, and this is very commonly discussed topic because we know tocilizumab IL-6 blocker useful for treatment of rheumatoid arthritis, as well as we recently discussed useful for treatment of cytokine release syndrome and COVID-19 infection and causing adverse effect of infection, hepatotoxicity, all these things. Anyway, tocilizumab interleukin 6 blocker. Proteasome blockers of bortezomib, carfilzomib, ixazomib useful for multiple myeloma. And this one question from ocular pharmacology, I think so. A patient with asthma developed a glaucoma. Which of following drug would be used for open angle glaucoma? Can you please answer? Patient with asthma having glaucoma, which of following drug will be useful for open angle glaucoma? Option given are latanoprost, carboprost, alpostadil, gemprost, all these things. What the answer? I think very straight question answer. Among this, only one drug is used for glaucoma, that is latanoprost. That's the answer. Other drugs are not for glaucoma. It's a PGF2 alpha agonist. Carboplatin PGF2 alpha useful for PPH, postpartum hemorrhage. PGE1 analog useful for erectile dysfunction. Gimprost PGE1 analog useful for abortion. So the right answer is option number A. I think these are the important questions I have recollected. Any other extra question you have made, please post to me. I will try to answer your question. Up to this, after recall, how do you feel? Can you please answer? All of you, please answer. After recalling pharmacology question, how do you feel? Whether pharmacology questions are easy or tough? Among around 25, 26 questions, how many of them are having good answer? How do you feel? Whatever the question posted by students, I collected and mentioned answer. Very easy. Very easy. Very good. Feeling good. Difficult was 70. Okay. Okay. Overall, the question is above easy, man. Not some for your level as a UG standard. Maybe simply some tricky questions are there, but overall, I think it's a good only. Very easy only. Okay. Diuretic safe in kidney failure. Loop diuretic mean furosemide, thiazide mean metronidazole. What is the option given? I don't know. CKD, hypertension CKD can go for aliscarin. Hypertension CKD go for aliscarin. You can go for aliscarin. Diuretic mean thiazide mean metronidazole. Loop mean furosemide. Okay. I think very basic questions are there. All for notes only. Very good. Congrats. All the best. Next time when I see you, you should be a very good postgraduate. All the very best. Now I just hand over my platform to other faculty. Okay.
All right.
Yes, madam.
Yes, sir. Thank you so much, sir.
Thank you, madam. Thank you, madam.
So, hi, everyone. I'm Dr. Deepthi, and I would be doing the OBGY recall. And I think sir took quite a lot of OBGY questions into pharmacology. So that makes my work easier as well. So I'm not going to teach you today at all. Okay, I'm just going to stick to the questions. Sir has already covered this one, right? So female with hypertension on preconceptional counseling, which drug is to be avoided? And it is ACE inhibitors. Yes, so the answer for this one is ACE inhibitors. Sir has already discussed this. Let's look at the next question. So there was a question where she said, the question said that the pregnant patient feels an urge to pass urine. FHR is heard in the right flank. It doesn't matter if it was right flank or left flank, but FHR towards the flank, infra-umbilical flattening. What is the presentation, right? So this was occipito-posterior, okay? So this was occipito-posterior, okay? Yes, so it is occipito-posterior for this one. Okay, let's go on to the third question. So most common complication expected in partial transverse vaginal septum. So once they say partial transverse vaginal septum, so there is going to be some form of obstruction, right? Also, they gave that patient had history of pelvic pain. Now, whether it was dysmenorrhea or whether it is chronic pelvic pain, it doesn't matter, right? The answer will remain as endometriosis. Okay, so the answer is B. It is going to be endometriosis, most likely complication with transverse vaginal septum. Okay, and it was a partial septum. Okay, let's go on to the fourth question. This again, sir has discussed. So 36 years old woman with painful vesicles in the vulva, and she was in labor. So somebody was asking with the answer change if she is in labor. No. So these are herpetic vesicles on the vulva. So active herpes or active lesions is an indication for a cesarean section, even if she is gone into labor, right? So the answer will be B, that is acyclovir, and do a cesarean section for her. Okay, let's look at the next one. So this was a question where the patient had come to you for primary infertility. She had a bilateral cornual block due to intramural fibroids. Not just that, they had also given the size of the fibroids. One was 5 into 7 centimeters, okay, and the other was 3 into 5 centimeters. The question also mentioned that husband's semen analysis is normal, the ovary is normal, and the best management was asked, right? So with these big fibroids causing the cornual block, even if they are intramural, the answer remains as laparoscopic myomectomy. It is not arch. Okay, so these big fibroids need to be removed. It is going to be laparoscopic myomectomy. All right. ART is assisted reproductive technique. So maybe they wrote ART, maybe they wrote IVF. I think in the option they wrote IVF. So even if they wrote IVF, the answer is lap myomectomy, and there is no doubt about that. This is the answer. Okay, let's go on to the next one. So 26-year-old patient with post-molar evacuation with cannonball metastasis and irregular bleeding. Yes, corneal block is same as ostial block, Kshitij. Okay, it is the same thing, beta, right? So this is a patient who has developed post-molar choriocarcinoma. Now, please remember, the other places are giving it as a wrong answer in the recall. This is going to be single agent chemotherapy. She is no doubt a low risk patient, right? So this is a low risk GTN. Metastasis to the lungs is considered as low risk. It is given a 0 score. 26 years old is given a 0 score. This is low risk GTN. It is not going to be imaco. That's a wrong answer given on the different places. It is not imaco. Okay, imaco is given for high risk GTN. This is not high risk. This is a low risk GTN. All right. So this is, yes, stage 3 is good prognosis. Metastasis to lungs is given a 0 score. It is a low risk GTN. The answer is single agent chemotherapy. It is methotrexate with folinic acid. Okay. Everyone should go and read then, whoever has given that answer. All right. Indomethacin, sir, has already given. So indomethacin given for prophylaxis at 36 weeks. What complication is seen? The answer is premature closure of ductus arteriosus, right? So sir has already covered this. No, there were no high risk features, Shubham. The age of the patient was 26. Okay. The metastasis is in lungs, which happens early. So this is no doubt stage 3, but it is a low risk GTN. All right. Then this was a question where the patient had 6 weeks amenorrhea, left adnexal mass, which is 3 centimeters in size. Okay. UPT is faint positive. HCG value is 2800. No cardiac activity. What is the management? The answer is single dose methotrexate. Okay. The answer is single dose methotrexate, not multi-dose. All right. So it's single dose methotrexate. Not expectant management. Expectant management is never done if you are seeing a gestational sac. All right. And for that, the HCG value has to be less than 200 and a falling trend. All right. So this is a single dose methotrexate, right? Yes, that's D. Okay. So there was a question on management of a uterine septum. Yes. So there was a question on management of uterine septum. The answer is hysteroscopic septoplasty. Okay. It is not metroplasty, right? So we don't do metroplasty. We do a hysteroscopic septoplasty or hysteroscopic resection of the septum. Okay. So that's the answer here. Let's look at the next one. This again, Pharma sir has already covered, right? So 36 weeks pregnancy on warfarin therapy. What is the next step? So it is stop warfarin and switch over to low molecular weight heparin, right? So switch over to heparin, all right? Yes, we'll come to that question. So condition not associated with uterine didelphius. So among the options given, the options were abortion, preterm transverse lie, endometriosis. The answer is endometriosis. Okay, they said not associated. So least likely with uterine didelphius is endometriosis. Okay, it is endometriosis. All right, then this again has been covered in pharmacology, drug interaction with OCP and anti-tubercular drugs. So this is rifampicin affects the metabolism of OCP. Yes, it's an enzyme inducer. So rifampicin affects the metabolism of OCP, right? Okay, so this was a question on second pregnancy with previous twin pregnancy. So this is G2P1, all right? So twin pregnancy is not included in parity. It is G2P1, all right? It is G2P1. Then this is a question which you have been debating about, and there is no debate on this one, okay? Stop going after uncommon things and uncommon explanations. So this was a patient with 8 weeks. Okay, one pregnancy loss at 8 weeks, second pregnancy loss at 11 weeks, both with no cardiac activity. And the third was a preterm delivery due to early onset preeclampsia. Yes, please understand this is the classic clinical history of APLA. The answer is APLA. It is not syphilis. Syphilis doesn't cause recurrent pregnancy loss. It actually causes stillbirths. Only the first one is an abortion in syphilis. The later ones are actually stillbirths. They are not abortions. So history of losses plus early onset preeclampsia is characteristic of APLA. Okay, it is not syphilis. That's an incorrect answer. Okay. Okay, so 28-year-old female with profuse white discharge, LMP was 13 days back. Yes, no pruritus, cycles are normal. She is anxious to conceive. What is the likely cause? Yes, so please remember this. This is going to be a physiological discharge. All right, so this is a physiological discharge, right? Typical history is she's around the time of ovulation. There is a white discharge, which is non-foul smelling. They haven't mentioned foul smelling, right? And no pruritus. So this is going to be a physiological discharge. All right. Okay. So this is again directly from the predictor series we did, right? So patient comes with missing 4 OCPs on different days, right? Twice in last 2 weeks. Okay. So 4 OCPs have been missed on different days in the last 2 weeks. So there were different options, right? So the option is that she has to continue the same pack, use barrier contraceptive, consider emergency pill if intercourse was, if there was intercourse in last 72 hours. Okay, so continue same packet, use barrier, consider emergency pill if there is intercourse in last 72 hours. All right. Right? Okay. So there was an image of uniconuvate uterus and they were asking you what investigation is to be done, right? So this was easy. This is HSG. All right. So this is HSG. All right. Okay. What is the best among these to identify Mullerian anomalies? HSG, ultrasound, lapro plus hysteroscopy, or only laparoscopy. So this is going to be laparoscopy plus hysteroscopy. Okay, so laparo plus hysteroscopy is going to be the answer here. Okay, let's look at the next one now. No, so Kadambala, it is always take 1 pill, never take 4 pills. This is directly what we did from the predictor series. Okay, so please remember, it is take 1 pill, not 4 pills. So take 1 pill from the same pack immediately, right? And then use it, use barrier contraceptive, and then if there is unprotected intercourse, then use EC, all right? So woman on OCP missed her period, LMP was 1.5 months back. How will you know the accurate gestational age? Okay, so this is going to be CRL. So gestational age is going to be CRL, all right? Okay, a lady with history of urination on coughing with cystocele. So this is going to be stress urinary incontinence. Okay, so stress urinary incontinence. Yes, the CRL is seen on transvaginal ultrasound only. Okay, but that is only TVS is not a specific answer. So it has to be a CRL measurement on the transvaginal ultrasound. Okay, then. So this was a question. Husband asked for paternal testing of twins. One son is found to be his, the other is not. What is the diagnosis? This is going to be superfecundation. Okay, it's not superfetation. It is superfecundation. This is again something that we directly talk in the class about as a typical example from the textbooks, right? So this is superfecundation, right? So those were the questions in gynae. I don't think I've missed any question. These are the ones that you have recalled, and please stop trying to prove your answers right. There is no point. As we said, this is a learning process, right? Syphilis answer nahi hai. Syphilis is not a known cause of RPL. Kitab khol ke dekhenge. It's not a cause of RPL. It actually causes more of stillbirths. There's only one abortion that it can do. The subsequent ones are stillbirths, and syphilis has no linkage to preeclampsia. Okay, your question had a clear cut part that the patient had preeclampsia. Okay, so there is no doubt on that. Okay, so please remember, it is not syphilis. Unusual चीजें सोचनी नहीं होती हैं एग्जाम में. फाइन बेटा, Cassavet's law में preeclampsia क्यों आएगा? हाँ, मुझे ये बताओ. Cassavet's law is simply that there is increase in the gestational age. That is exactly what I'm saying. That the first one would be an abortion and the subsequent ones would be stillbirths. That is after 20 weeks. And here, especially they had mentioned both the abortions, there was no cardiac activity, there was early onset, preeclampsia. Preeclampsia hone se likhte hi, the answer becomes APLA. It is not syphilis. Okay. So there is no point worrying now. Okay, it's done. Okay, the didelphius one. So see, all Mullerian anomalies can actually cause endometriosis as well, but here typically the answer is endometriosis, because when you say didelphius, there is no retrograde flow, right? So there is no retrograde flow because there is usually no obstruction. There is a vertical septum, so there is no obstruction. So abortions, preterm, transverse lie. So whenever the space available is less, okay, there are going to be malpresentations. So there could be transverse lie, there could be other malpresentations as well. So endometriosis is what is the best answer among the options. No milking of tube is never done. So no expectant management, no milking of tube. Okay. All right. बेटा टॉर्च तो कभी शुभांगी आरपीएल करता ही नहीं है, ये तो सबसे बड़ी बात है. टॉर्च इज नेवर अ कॉज ऑफ रिकरेंट प्रेगनेंसी लॉस. ऑलराइट, yes, so please remember this. These are very basic things. So torch doesn't cause recurrent pregnancy losses. No, superfetation has not been described in humans. Superfetation is only a theoretical concept. Again, you're going for rare things. All right, so it has to be superfecundation. It's a typical example. हमारी गायनी की किताबों में example है जो मैं class में भी देती हूँ. That twins are born, one baby is black and one is white to a white woman. Right, so this is a typical example of superfecundation. All right. Any other doubts? What was the question on Sheehan's? So I'm sure you guys have done well. See, it is a very natural response that after the exams you do feel, and a lot of you actually don't even remember the things properly. So as Dr. Sumer said, don't try and speculate. It is okay what has happened. बहुत सारे लोग अपने अपना recall दे देते हैं to prove their answers right. So don't get worried about that. All right. So please don't be worried. Huh? What was the question on Sheehan's? PPH made devascularization. Yes, there was a question on that. I will tell you the answer because I had it. I think I forgot to put it. So the first vessel to be devascularized is uterine artery, followed by ovarian, followed by internal iliac, right? So uterine, फिर ovarian, फिर internal iliac. Okay, that was the question. Subsequent devascularization that is to be done. Yes. Okay. I think Sheehan's wala, maybe people have given that question to the medicine faculty. I didn't get it in the OBGY recall, right? Okay, yes. So failure of lactation and after delivery, yes, that would be Sheehan's syndrome. Yes, the most common presentation of Sheehan's is failure of ligation. All right. Yes, that would be Sheehan's, and I'm sure you all have done it right. That is an easy one. वो आसान है. Anything else that you want to ask me? नो रामाकृष्णा, जैसे मैंने बोला आप लोगों का इनिशियल रिस्पॉन्स डिनायल है और खाली वो आपका नहीं है, वो मेरा भी होता है had I been in your place, right? So please remember, I've asked multiple people, there was no itching in the question, it was not foul smelling, it was just copious or probably profuse white discharge with no other symptoms at all. Typically 13th day or mid-cycle is given. Okay, it is physiological. All right. Yes, anything else? Otherwise, we'll shift over. But salpingectomy is never the preferred option in these younger women. You do salpingectomy if there is an indication to it. Out of the treatments, always the preferred option is medical as long as the clinical criteria are met. And in your patient, all criteria for medical management are met. So the answer is single dose methotrexate. Okay, so single dose methotrexate. Anything else? बच्चे 3D अल्ट्रासाउंड ऑप्शन में ही नहीं था चिली पोटैटो, ठीक है? सो जो ऑप्शन में था उसी में से आंसर करोगे ना, या अपने आप ऑप्शन भी लगा कर आओगे, राइट? So the best is lapro plus histro. It is too invasive. That is why it is never done. So these days the IOC is a 3D ultrasound. Okay. Anything else? All right. Chalo. So I think we will go on to the next subject. I think psychiatry. Are you ready? Okay.
Yes, ma'am. Hi.
Okay, yes, there was a question on fetus receives deoxygenated blood. It wasn't oxygenated. I think it was deoxygenated. So if it's deoxygenated, it is umbilical artery. If it's oxygenated, it is umbilical vein. ठीक है, but मेरे ख्याल से exam में deoxygenated था, and that is umbilical artery. All right. Yes, I already gave you the answer for the ovarian artery. That was progressive devascularization. So initially uterine artery, then ovarian, then internal iliac. Okay.
All right. So I hope we can begin psychiatry now. Yes. Okay. So I don't have too many questions, so I'll not take much of your time. It is very simple, like 6 questions we had. And as per the prediction, 1 question belonged to general psychiatry, because 1 question out of 6 is usually based on symptomatology, and 1 question belonged to general psychiatry. Then your couple of questions on clinical psychiatry, and couple of questions on substance use, and 1 question on psychology. Initially, when I recalled, it was 4 questions, but later on I came to know a couple of more questions. So let us discuss 6 questions. Ready? Very simple questions. First question: a schizophrenia patient was having obsessions, thought insertion, derailment, and delusion of persecution. Which of these is included in formal thought disorder? Okay, this is the most recalled question of psychiatry, and it was very easy and very much solvable. because this is the first topic of the class. Thought disorders are divided into form of thought, content of thought, position of thought, and stream of thought. Form, content, position, and stream. And form of thought includes loosening of association, LOA. Loosening of association, and which is a disorder of form of thought, derailment. And as I always say, obsession is content. Delusion is content of thought. All right. So there was nothing great about this question, a single straight question. Most of the questions students have got this correct. Derailment is loosening of association, which is a disorder of form of thought. I hope no doubt about this question. I'm looking at the chat. Yes, this was in the last mile revision. Okay. Yes, this was in the last mile revision. Okay. Done? Okay, number 2. A 16-year-old female patient presented with overfamiliarity. Overfamiliarity itself suggests you a diagnosis. Flight of ideas. I have taught you flight of ideas in only one single condition, and all of you know that condition is called mania. Flight of ideas is a simple, straightforward answer. Elevated mood. Okay, elevated mood. Increased sexual desires. Even if pseudo hallucination is given or not given. Now some students were asking, sir, why not hypomania? Duration was not given. So if duration was not given, why did you think of hypomania? As simple, flight of idea, mania, very simple. Sir, what is schizomania? Did I teach you schizomania? No. So do you need to know schizomania? No. It is the older name of schizoaffective. Schizoaffective had a manic predominant subtype and a depressive predominant subtype. Okay. So schizomania is nothing but a schizoaffective disorder. I hope some of you know what is a schizoaffective disorder, in which psychotic symptom and schizophrenic symptoms and mood symptom coexist. Psychotic symptom and mood symptom coexist. Okay. Schizomania is nothing. Schizomania is nothing. So schizomania is schizoaffective. It is the old name. Cyclothymia, we all know it is a mood fluctuation state. And this is not a hypomania. This is mania. Very simple. If I would have asked you a one-liner, flight of ideas seen in, what would you have marked? Mania. As simple as possible. Okay. Next question. Now this question had different languages, of recall. Some students were recalling it different. Some students were recalling it different, but the meaning is the same. It is the therapist feelings towards the patient. Therapist doesn't keep in mind what the patient wants and is giving a biased opinion. Okay. Therapist keeps his own unmet needs toward the patient. Therapist is doing in his way. Countertransference. Countertransference. Nothing great about it. Transference is the patient's reaction towards the therapist. Countertransference is the therapist's reaction toward the patient. The term therapeutic alliance is reused with respect to the relationship between physiotherapist and the patient. Dissociation is dissociative amnesia, dissociative identity disorder. What is preoccupation? Many students mark it preoccupation. Did anyone taught you what is preoccupation? Did I teach you what is preoccupation? Is preoccupation a symptom? I only have taught preoccupation in grief, when the person is preoccupied with the thoughts of dead one. Okay, as simple as that. Question 4. It is a NEET repeat question and it has been repeated many times in the classes as well. Alcoholic withdrawal, 72 hours, irritability, disoriented, altered sensorium, visual hallucination, delirium tremens. Very simple. There's no history of seizures, so no alcohol withdrawal seizure. No history of global confusion, ophthalmoplegia, ataxia, so no Wernicke's. No history of amnesia plus confabulation, so no Korsakoff. As simple as that. Delirium tremens. Now question 5, you may call it as a forensic medicine question, you may call it as a psychiatric question. Anybody can answer this. An old patient was sitting in the balcony naked, showing his body parts. So showing the body parts, exhibitionism. Exhibitionism. Showing the body parts, exhibitionism. Watching others getting intimate, voyeurism, peeping Tom, fetishism, non-living objects. These are all paraphilias, sexual perversions. Masochism, getting inflicted pain from others. Sixth and the last question. This question initially I answered as hypothermia. Later I changed my answer because I thought they are asking you a concept. Actually, cocaine is the only drug that causes tachycardia and bradycardia both. Cocaine technically, theoretically is a sympathetomimetic. So it releases norepinephrine, so it causes tachycardia. But there are reports of bradycardia also with cocaine. But I thought then when I realized all the options and analyzed all the options are up, agitation, hyperthermia, myocardial infarct. So they are just asking about the one aspect of cocaine, not the other aspect of cocaine. The other aspect of cocaine is bradycardia, which is not very, very common. Cocaine causes tachy and brady both. Tachycardia more common than bradycardia. That's why we are answering this question as bradycardia. That's why we are. Cocaine is known to cause myocardial infarct. Cocaine, and you know, some students were able to mark this very easily. Sir, you said cocaine is a stimulant. Stimulant means up. Cocaine intox, up. Anybody remembers? X, 2x, reverse of X. Action is X, double is intox, reverse is withdrawal. So these are all the psychiatric questions we have. I hope most of you have got most of these correct, and I had this much only to say. And that psychomotor cognitive learning question, what you're asking me, it is a direct statement from Part PSM. So I have already referred that question to the PSM department, and alprazolam question is already referred to the pharmacology department. So these are my 6 questions. Okay. I want to know in the comments how many of you have got out of 6, how many correct? Because you have been asking each other how many correct. So I can also ask you how many correct, because somebody must have got 6 on 6. Somebody must have got 5 on 6. Okay. 5 out of 6. Very good. Go ahead. Wish you all the best for results. We are starting a personal mentorship session and a career counseling session. Dr. Sumer sir has already announced that. So if any one of you wants to get in touch with any one of us, including myself, ma'am or sir or any faculty, you are more than welcome to discuss. Wish you all the best for results. Okay. Hope to see you soon in career counseling event. We'll announce that very soon. Thank you.
Dr. Poonam, are you next?
Yes, I am here. So good evening all. So can I start it now?
Yes, madam. Yes, ma'am. Please share the screen. Yes,
All right, thank you. So good evening, everybody. This is NEET Recall 2021 for biochemistry. I have collected total 17 questions from various sources. I'll be just telling you the answers of those questions, and the detail will be discussed in the video, which you'll be getting shortly. This is number 1 question, where a child is presenting with so just a second. So child is presenting with night blindness, biter spot, and dermatological finding is given as below. You can see the papule-like lesions on the back of the arm. Now, what is the diagnosis? So the answer in this question is phrenoderma, which is due to deficiency of many of the vitamins. The most important one is vitamin A deficiency, but there are many other vitamins which are responsible for deficiency of which is responsible for phytoderma, like B complex, vitamin E, and even the essential fatty acid deficiency. So in this case presentation, the whititis spot and night blindness is a hint towards the vitamin A deficiency. And because the vitamin A, prevents the keratinization, its deficiency results in hyperkeratinization, which is resulting in phytoderma-like features. The second question is this hyperpigmentation around the neck area, which is given in the picture. Now, what is the possible vitamin deficiency in this case? The question mentioned that the patient is a farmer who is growing maize. So what may be the possible deficiency? So that was a strong hint. Maize growing population, the population which is mainly dependent on maize as a staple diet, tend to have deficiency of niacin because maize are having deficient tryptophan, and the niacin also is present in the bound form, and the niacin deficiency results in pellagra, and this is Kessel necklace deformity, which is because of niacin deficiency. So the options were probably folic acid, pyridoxine, niacin, and thiamine. So answer is going to be niacin. The next question asked was 10-year-old child who is presenting with frequent URI, upper respiratory infection. Stool was greasy and fat content was high. Means the patient was having steatorrhea. Now, what is the true statement regarding this condition? As per clinical history, it looks like a case of cystic fibrosis. And the true statement in cystic fibrosis out of all these options is going to be protein losing enteropathy, because along with loss of lipid in the stool, the patient also have loss of protein in the stool because the pancreatic enzymes are deficient, which are needed to digest the protein in the intestinal lumen. So that is going to be the best answer here, the protein losing enteropathy. The next question is talking to you about a person who is reporting with tendon xanthomas, and serum cholesterol and LDL level was given, and it was both high. The cholesterol was 398 milligram per deciliter and LDL was 220 milligram per deciliter. Normal value of cholesterol is less than 200. Desirable level is less than 200 milligram per deciliter, and LDL is approximately 100 milligram per deciliter. So in this case, both of these levels were elevated. Treatment with this statin was initiated. And what may be the most probable diagnosis? So this is all different types of hyperlipidemias which were given in the option. And as the case presentation is given for, it's a clear-cut case of hypercholesterolemia, familial hypercholesterolemia, which is one of the commonest hyperlipidemia which we encounter, where there is problem in the either in the LDL receptor or there is mutation on ApoB100 protein. So that results in non-clearance of LDL particle from the plasma, and LDL is increased in the plasma. And you know, whenever we assess the cholesterol in lipid profile, the main source of cholesterol is the LDL particle. So if LDL is high, the total cholesterol also is going to be high. So it's a clear-cut case of familial hypercholesterolemia. Now coming to the next question, which is talking to you about 4-year-old boys presenting with developmental delay, recurrent chest infection, bone pain, PTH and calcium was normal, phosphate was low, that is 2 milligram per deciliter. Phosphate normal level is 3.5 to 5.5 milligram per deciliter. In this child, the phosphate is low. Otherwise, PTH and calcium is normal. Patient is not showing any improvement with the vitamin D. What is the most probable diagnosis? The answer in this question is, after ruling out other options, the answer is going to be X-linked hypophosphatemic rickets. The detail how to exclude each and every option, how to come to a conclusion, whether it is vitamin D dependent, type 1 or type 2, or X-linked or nutritional rickets, I will be posting a video on it. Coming to the next question, which is a 60-year-old diabetic patient presenting with repeated vomiting following a recent dine out. BP was 90 by 60, which is of course a low BP. And the biochemical finding given was pH 7.5, which is towards the alkalotic range. Bicarbonate again is slightly high, it is 28 millikelvin per liter, and carbon dioxide is 40 millimeter of mercury, which is high range of normal. So what may be this case? Repeated vomiting, BP low, and pH on alkalotic side, bicarbonate also on higher side. It's a case of metabolic alkalosis. How to identify that whether it is acidosis or alkalosis? Of course, it is easy. You can see pH. Normal pH is 7.35 to 7.45. And if it is below this normal range, it is acidotic pH. And if it is in the higher range, it's alkalotic pH. So identifying whether it is acidotic or alkalotic is not difficult, but to find out whether it is metabolic or respiratory, you need to focus upon the bicarbonate level, which is higher in this case. Detail will be discussed in the video. Now coming to next question, which is a patient presenting with hysterical woman presenting with hyperventilation, and woman is having carpopedal spasm. So that is a very, very common case which you may encounter during emergency ward posting. So carpopedal spasm, this may be because of what? So carpopedal spasm, you understand the effective calcium is low, the ionized calcium. Ionized calcium is effective calcium, that's low. Whenever you talk about total calcium, that's not going to change. Whether it is hyperventilating or hypoventilating, total content of calcium will be normal. But when you talk about ionized calcium, that's going to change depending upon the rate of respiration. In hyperventilation, what happens? There is increased carbon dioxide wash off that results in alkalosis, respiratory alkalosis. So this patient, this woman is having respiratory alkalosis that is resulting in more of the negativity on albumin, and that results in more of the binding of calcium. Because albumin is negative, the calcium is positive ion, they tend to bind each other. So bound form of calcium is increased and free form of calcium is decreased. But the total calcium is going to be the same. So whenever we talk about this question, the high total calcium, low total calcium is not the answer, because total calcium is going to be the same. It is only the ionized form which is going to change. And in hyperventilating women, because of respiratory alkalosis, more of the negativity of albumin, more of the calcium will be binding, and the ionized calcium level will be low. And that is the reason that this patient is developing carpopedal spasm. So the best answer here is going to be alkalosis, respiratory alkalosis. Next question is talking to you about calculation of total sodium deficit. And the weight of a person is given. Serum sodium, estimated sodium is given as 120 millikelvin per liter, which is certainly very low. The normal level of sodium, if you consider as 140 millikelvin per liter, though it is in the range of 135 millikelvin per liter to 145 millikelvin per liter. If you take a mean and you say it is 140 millikelvin per liter, you understand that serum sodium is very low. Now the question is how to calculate sodium deficit. You have a particular formula to calculate the sodium deficit, and the calculation of sodium deficit is done to plan the replacement, right? Replacement of the sodium by giving sodium chloride. And that formula says that the sodium deficit is going to be, the formula says it's a desired sodium minus estimated sodium multiplied by 0.6 multiplied by weight of that person. So if you use this formula and estimate what is the sodium deficit in this person, you get the value of 840 millikelvin per liter. Now coming to next question number 9. It's a core biochemistry question. See, what I have noticed that in this paper, there is a right blend of clinical biochemistry, where clinical cases are given and the related biochemistry is being asked. And at the same time, you have diagnostic biochemistry, where lab-based parameters are given and the questions are asked to you. And similarly, I can say 33% of the questions were from hardcore biochemistry. So this was a right blend of all three sorts of biochemistry. So that shows that you have to pay attention to all aspects of biochemistry. It's not just hardcore biochemistry you have to understand. You have to understand clinical biochemistry, learn it, and even the diagnostic lab-based biochemistry also you must be aware. Coming to this question, which is from metabolic pathway, and it's a very straightforward question, which is talking to you about cystathione beta synthase deficiency. A person is having this particular enzyme deficiency. What amino acid supplementation is required? So for answering this question, you must know that this particular enzyme is required for the synthesis of cysteine in the methionine metabolism. Whenever methionine is metabolized in the liver, it is going to form you cysteine. So methionine is essential amino acid and cysteine is non-essential amino acid. There are multiple steps to it. And one of the enzyme is cystathione beta synthase. So if that is deficient, of course, the cysteine will not be synthesized. So if they ask you which amino acid need to be supplemented, the answer is going to be cysteine. Now, coming to 10th question, 5-year-old male is presenting with anemia. Male child is presenting with anemia, bone pain, hepatosplenomegaly, and macrophages, probably the hint was given as macrophages were showing the crumbled tissue paper appearance. Then what is the deficient enzyme? So this was crumbled, the major hint was crumbled tissue paper appearance, and when that is given, it denotes that it's a case of Gaucher's disease. So if it's a Gaucher's disease, of course, the enzyme deficiency is going to be glucosidase or glucocerebrosidase. So most of the time they ask you mucopolysaccharidosis. This time, unusually, they have asked you Gaucher's disease, which is sphingolipidosis. So you must know about various storage disorders. Right? All right, so now coming to question number 11. I'm not sure if this kind of picture was given, but you can see in this picture, this is crumbled tissue paper appearance, which is very much characteristic of Gaucher's disease, and detail I'll be discussing in the video discussion. Right, now coming to the next question, number 11. A glucose transporter in the adipose cell. So a beautiful question. Many number of times they ask question on glucose transporter, and I'm not sure about the cell because there is a little controversy, but if it is adipose cell, of course, the answer is going to be GLUT4. So GLUT4 is the transporter which is present at 3 different places, that is adipose cell, skeletal, and heart muscle. Right? First image was given. So very good. Spirit ghost. So Gaucher's disease में आपको crumbled tissue paper appearance was shown. Now, intestine में था. If it is intestine, then the question will be different, because if you talk about the glucose transporter in the intestine, you'll have SGLT1, SGLT2, as well as GLUT2, all 3 of them. So the apical side of the intestine, it will be SGLT1 and 2, and the basolateral side, it is going to be GLUT2. So now depends now which cell was asked. If it is adipose cell, answer is going to be GLUT4. If it is intestinal cell, then they will ask you all the following glucose transporters are present except, right? That time again, answer will be GLUT4. Now depends what was the correct recall. All right. Yes, that is what I'm telling. If the question was intestine, then see at the apical side, you have sodium glucose transporter 1 and 2, and towards the basolateral side, you have GLUT2. So that time, the only one GLUT which is not present at intestinal cell will be GLUT4. For GLUT4, you always remember there are 3 organs: adipose, heart, and skeletal muscle. Coming to next question, number 12. Which is asking you about a 7-week-old baby is brought by the mother with complaint of repeated, it's hiding, let me read it, repeated projectile vomiting, right? Repeated projectile vomiting and pellet kind of stool. So it's a clear-cut case of hypochloremic, hypokalemic metabolic alkalosis, right? So answer is the second one. This is the condition the baby is suffering. No more hint was given. Right. Now coming to next question. Now, this was a straightforward question, which is very much repeated. Right. Now, type of defect which is seen in HNPCC. It's a very frequently repeated question. It's a hereditary non-polyposis colon cancer. This is one of the repair defect in the DNA, which is resulting in this kind of problem where there is no polyp on colonoscopy. And this is called hereditary non-polyposis colon cancer. And this is due to defected mismatch repair system. Right. Now coming to next question, which is 14th question. Right, wait, I will come to that question. Right, next question says that a person had last meal at 8 p.m. and gave the blood sample at 7 a.m. in the morning. So what pathway is responsible for maintaining the blood glucose level at this time? So if you see the time span, which is given here after taking the last meal, it's 11 hours. So 11 hours, what is the process which is maintaining at the end of 11 hours? What is the process which is able to maintain the blood glucose level? Now, as I have got the recall options, the gluconeogenesis as well as liver glycogenolysis, both were there in the option. So the best answer is going to be liver glycogenolysis, because at this particular time when 11 hours is being talked about, liver glycogenolysis is going at peak rate. Gluconeogenesis, though, has started, but it's producing very little amount of glucose at this point of time. So as I have understood the question, the best answer is going to be liver glycogenolysis. Nobody is telling me what was the fourth option. Diet glucose. Okay, somebody is telling dietary glucose was also one option. If that was the option, please understand that dietary glucose will last for very little time, only 1.5 to 2 hours. So that will not at all the answer. And muscle glycogenolysis also will never be answered, because muscle glycogenolysis never gives you blood glucose. So the confusion will be between A and C option. But if you go according to my concept, my understanding of this question concept overall, the best answer is going to be liver glycogenolysis. Dietary sodium and dietary glucose can never be answered, because your dietary glucose will last only for 1.5 to 2 hours. If you radio label all the carbons of the glucose which you're eating, that radio labeling will be disappearing from the plasma very soon, within 2 hours. Now, there was a question previous question. Yeah, just 1 second. I would like to add one more thing into this spirit course, so that you don't have any confusion. Whenever we talk about liver glycogenolysis, please understand, depending upon the nutritional status of the person and the body build, the liver glycogen lasts for 18 to 24 hours. 18 to 24 hours. And liver glycogenolysis begins after 4 hours of fasting and, peaks at around 10 to 11 hours. And the total stock of glycogen, gets abolished by 18 to 24 hours. So in my opinion, this is the best answer here. Now coming to the next question, where PDH complex was shown, and they asked you to label the correct order of the enzymes. Like, this is how the PDH complex is there, where the pyruvate is converted to acetyl-CoE. Now you need to have 3 enzymes and 5 coenzymes in this whole process. The correct order, now depending on the option, like whichever option was talking to you about this particular order of enzyme, that is pyruvate dehydrogenase, dihydrolipyl transacetylase, and dihydrolipyl dehydrogenase enzyme, it's going to be the answer, because this is the correct order of enzymes which is required for PDH complex action. And pyruvate dehydrogenase is also called as pyruvate decarboxylase enzyme. So if any option was there, like pyruvate decarboxylase, dihydrolipyl transacetylase, dihydrolipyl dehydrogenase, then the answer will be that option only. Yes. Okay. All right. Now coming to, yes, E2 transacetylase. All right. E1 is pyruvate dehydrogenase, E2 is transacetylase, and E3 is again dehydrogenase, right? All right. I will just come to that question, Ganguly, and just wait for 2 more minutes. Now, there was a question which is a straightforward question. The clear-cut hint was given, that's the case of alkaptonuria, where black color urine history is there and black discoloration of cartilages are also given. What is the enzyme deficiency? It's a straightforward case of alkaptonuria, and in alkaptonuria you have homogenesic acid dioxygenase enzyme deficiency. So this will be the answer, and the whole pathway which is involved in this alkaptonuria I'll be discussing in detail in the video. Now coming to the question number 16. Now you were waiting for this question, Devashis. Let's see about this question. There was a lot of controversy in the recall of this question, but somehow I have understood that this question was a little tricky one, and the question was asking that oxygen in some experiment, the oxygen uptake level in a cell was checked. When the pyruvate, malate, and succinate, I guess, was added, the oxygen uptake was increased and ATP production was also increased, which is quite expected when you're adding the substrate of TCA cycle or the glycolysis. Of course, the oxygen consumption as well as the ATP production will increase. So first line says it's a normal phenomena, but the second line is actually telling you, but on addition of one strange substance, the ATP production declined drastically. What may be that substance? So in other words, this is asking you what may be the substance out of these options which will reduce the ATP production drastically. So the answer is going to be 2,4-dinitrophenol, because this 2,4-dinitrophenol is chemical uncoupler, which is dissociating the process of oxidation and phosphorylation. So the oxidation will proceed at the normal rate. Oxygen consumption will be increased on adding these substrates like malate and pyruvate, but ATP production will be reduced. So that is called dissociation or uncoupling. So the best answer here is going to be 2,4-dinitrophenol, right? All right, now coming to the next question, number 17, where corneal transparency question was asked, and in fact, there are, if this is the correct to recall, there are two answers which is correct, the keratan sulfate and dermatan sulfate. But if you have to select one, the answer is going to be keratan sulfate, because that is largely responsible for transparency of cornea. All right, thank you very much. So these are 17 questions which I have collected. If any other question, you can inbox me.
Ma'am, you're on mute.
Remember, we can't hear you. हेलो मैम, आप एक बार उसमें देखना ऑडियो सेटिंग्स में जाके माइक आप देखना कौन सा सेलेक्ट किया हुआ आपने ना, कभी कभी वो सिस्टम की जगह दूसरा माइक सिलेक्ट हो जाता है ना। नीचे जाके जहाँ माइक होता है वहाँ पे आप सिलेक्ट माइक्रोफोन में आप जाके सेलेक्ट करो। आई कांट हियर यू मैडम इधर। नीचे जो माइक आ रहा है ना, नीचे जो ऑप्शंस के अंदर माइक का जो एरो होगा उसे क्लिक करेंगे, सिलेक्ट अ माइक्रोफोन में जाएंगे ना, तो आप माइक को उठा पाएंगे।
हेलो
ma'am, where the mute button is, just go to the mute button. There is a arrow pointing upwards. Just click on that arrow. There is a select a speaker. So select the speaker, you click on the speaker and then the voice will come.
आ नहीं रहा मैम, आवाज नहीं आ रहा, आवाज नहीं आ रहा। आपने ना वो जो सिलेक्ट माइक्रोफोन आ रहा होगा आपके वहां पे, उसमें आपने आपका सरफेस को सिलेक्ट करना पड़ेगा, लैपटॉप। एक काम करते हैं मैम, हम पहले दूसरा सब्जेक्ट कर लेते हैं, आप उस सिस्टम को रिस्टार्ट कर लो, एक बार रिस्टार्ट कर लो, आई थिंक दैट माइट हेल्प यू, है ना। सो आई थिंक what we will do here is, by the time madam gets it all set to go, what I'll do is I'll quickly cover up the radiology part for you, so that there is nothing missing for you and we are able to do. Radiology was mostly straightforward, or zyadatar it was all discussed in the classes, so it should take us hardly 10 minutes to do the radiology part. Okay, dekhein. Okay, so let's start. First question. This was a patient with injury with a suspected foreign body in eye, है ना। कोई लोग कह रहे थे कि foreign body था या नहीं था, लेकिन ocular trauma था। So always remember, investigation of choice for ocular trauma is a CT scan, NCCT. Investigation of choice is NCCT. So CT is ruled out क्योंकि पूछा था which of the following is detrimental. They had asked which of the following is detrimental. So definitely CT is not the answer. So out of the choices which are left, we have to remember that MRI could be detrimental here, because if you have a metallic foreign body or a ferromagnetic foreign body and you do a MRI, it will cause further damage. And I have with us Dr. Saurabh also. I'll ask him to comment quickly here if he's available to close this discussion.
Yes, sir, I'm here. Of course, MRI is contraindicated if there is a metallic foreign body. So here the most common, most detrimental would be, of course, MRI. But if the question, someone was saying that question was investigation of choice, then correctly the answer will be non-contrast CT scan.
Yeah. That's why I said if they have asked what is most useful, answer will be NCCT. What could be most harmful, then the answer will be MRI. And probably most of the students were of the opinion that they had asked detrimental. Okay. And another thing I wanted to mention here is that usually whenever we are looking at a patient with orbital trauma, MRI is something that I will always keep in mind that even if there is no history of foreign body, but there could be a foreign body after an accident, so I will not go for MRI at the initial part here. Okay, and I think most of you agree that it was detrimental, so we will not go further into it. Next is a question where this is a previous NEET PG repeat question, and I am so happy that many of you followed my advice to do the previous NEET PG paper questions from the eMedicos app. They repeat one or two topics, and even before the exam I had told you. So this was a patient with repeated miscarriage. Okay, this was the image shown. This is the cervical cannula, and you can see a unicornate uterus. Okay, what do you think? What do you think? HSG. This was a hysterosalpingogram. You would not do a CT scan for a patient who is infertile, because CT scan has radiation. You would not do it in an infertility. This is not the answer. Saline histogram is with an ultrasound image. So saline hysterosalpingogram is done with ultrasound. So you should see an ultrasound image. This is an X-ray image. So clearly the answer was HSG. Are you clear, everybody? Okay, great. So let's see this next question. Next question was, I don't have the exact image, but what I have learned from students was there was a image showing a swelling of the hand and image X-ray showing a tumor. So where is the tumor located? Lower end of the radius. Where? So there was a tumor in the lower end of the radius in the epiphysis with subarticular extension. It is reaching just till the joint. So it is subarticular, eccentrically placed, so bubble-like appearance, expansile. What do you think is the answer? Definitely the answer is giant cell tumor. GCT was the answer. And if you now go back and see in our classes, when I was discussing this GCT, I told you out of simple bone cyst, giant cell tumor, and aneurysmal bone cyst, one is every year asked in NEET PG. And if you add to it chondroblastoma, definitely you will get a question in the next NEET PG 2022 also. So if you are hearing us later on, in 2-3 months later, please remember this: bone tumor, especially GCT, simple bone cyst, aneurysmal bone cyst, chondroblastoma. One of them is always asked in the NEET PG exam. Okay, so next question. So this was a straightforward question. I've already discussed this on YouTube channel, where you have right side kidney was shrunken with calcification. Shrunken with calcification. So unilateral tubercular kidney, end stage tubercular kidney is called as cement kidney, autonephrectomy, or putty kidney, and that was the answer. Even the sterile pyuria given in the choices in the question was a important clue. So abdominal pain, sterile pyuria, calcified putty kidney, contracted, answer is tubercular kidney. We've already discussed this at length in this very channel, so you can actually go back and see it again. Child with fatigue, 12-year-old child, what is the image showing us? So again, if you look back at our classes, you will see in every of my class I have mentioned one congenital heart disease. One congenital heart disease X-ray is every year shown in the NEET PG exam. And I want you to see, okay, I want you to see in front of you, and can you tell me what are you able to see? You are able to see the snowman heart seen in the supracardiac TAPVC, supracardiac TAPVC, pulmonary plethora, snowman heart. This was the answer. The answer is TAPVC. Clear? And again, if you notice, in the last year's NEET PG also there was a question. They had said cyanotic heart disease with plethora with TAPVC as the answer. Again, I am telling you, if you are a NEET PG 2022 aspirant listening to me right now, focus on your class notes, focus on DBT, and in the last week, do not forget to look at the NEET PG solutions on the eMedicos app. They will give you an extra edge. Okay. Okay. Next was a middle-aged person with 2-year history of backache with redness of eye. So backache with redness of eye with the X-ray showing us, what is the X-ray showing us? Bamboo spine. So the X-ray was showing us bamboo spine, and redness of eye could be because of uveitis, backache. The answer is ankylosing spondylitis. Why this is not tubercular spine? In tuberculosis of spine, you would see disc space narrowing with paraspinal abscess. In TB, you will see disc space narrowing with paraspinal abscess. Disc prolapse, it is difficult to diagnose on a plain X-ray AP view. You will diagnose disc prolapse on a MRI. Osteopetrosis, you will see Rugger jersey appearance and bone within bone appearance. Are you clear, everybody? So I'm sure you all got it right. The answer here was ankylosing spondylitis. But just to make sure that you enjoy the discussion at the midnight, I want you to look at this area also. These are your sacroiliac joints. If I zoom the image, there is erosions as well as sclerosis, partial obliteration of the SI joints. So you can see SI joints are also involved. Sacroiliitis, bilateral, bamboo spine, uveitis. Answer is ankylosing spondylitis. Are you clear? Okay, let's see. So next is, which part of the bowel is dilated in the X-ray shown to you? So this was shown to you in the X-ray, and I want you to see. And regarding that congenital heart disease X-ray, Chaya and everybody on the chat box, मैंने देखा आप सब पूछ रहे हैं कि टॉफ था कि वो था. तो बेटा देखो, बहुत सारे बच्चों से हमने बात की है, ज्यादातर लोग का मानना है कि TAPVC था वहां पे. ओके, टॉफ पिछले साल आया था, इस साल TAPVC था. ओके ओके. Another thing I want you to see is this one. So what do you see? These are small bowel loops which have volvulae conniventis. These are your complete folds called as volvulae conniventis. Once you see them, the answer is jejunum. In ileum, ileum is a featureless loop. It is a characterless loop. Colon will have incomplete folds called as hostrae. The answer was jejunum. Clear? Okay. Let's go further now. Okay. So next X-ray was patient with abdominal distension and emergency. This was the X-ray. Over the liver area, there was lucency. Although many students said that you could not clearly see gas on the diaphragm, but over the liver area, there was some lucency. And if I zoom it, you could see both sides of the bowel wall. You could see both sides of the bowel wall. This appearance where you are able to see both sides of the bowel wall is called as the Wriggler sign. Okay, Wriggler sign is a sign of pneumoperitoneum. Wriggler sign is a sign of pneumoperitoneum. And I also want you to know, very important question. Okay, very important question. Prachi is asked, sir, wo TGA kyun nahi hai? Transposition of great arteries kyun nahi hai? TGA is usually a newborn with cyanosis and an egg on side heart. That was not in the question. Okay. Now, one thing I want you to notice here is this was pneumoperitoneum. Definitely, most of the students I've talked to you believe that it was pneumoperitoneum. But also remember, there is something called as Wriggler's triad. Wriggler's triad is seen in gallstone ileus, where you have a radiopaque gallstone, pneumobilia, and small bowel obstruction. Okay, clear? Okay. Another question where we saw a lot of students having a debate: child with normal bone mineralization. So what happens is rickets is a disease with defective bone mineralization. Scurvy is a disease where you have defective osteoid formation, but mineralization is preserved. You could see these Pelkan spurs, white line of Frankel, and the epiphysis had a sclerotic rim, which is called as the Wimberger's ring. So the answer here was scurvy. The answer to this question was scurvy, and we have at length discussed the radiological features of scurvy in our classes. So I'm sure you all got it right. Diaphyseal ecclesia, okay. Okay, perforation and pneumoperitoneum would mean the same thing, beta, Chaitanya and everything. I hope you know. I hope you're not nitpicking, na. Perforation लिखा है तो perforation से ही तो pneumoperitoneum होगा ना. तो थोड़ा सा समझ लेते हैं ना. A diaphyseal ecclesia is a syndrome with multiple exostosis. That was not in the image. And rickets, you already know, you will have cupping, splaying, and fraying of the metaphysis. Okay, let's go further. Now, again, this was a question that I had shown to you in the ER room discussion. In the DAMS emergency room discussion, we had discussed that if you see a coin in full round shape in the coronal plane, this is definitely in the esophagus. And in the lateral view, you can see it is behind the trachea. This was definitely a coin in the esophagus. They had asked to tell us where is the foreign body. They had not said कि क्या चीज है foreign body. They had not said कि coin है कि पहचानो. They had only said where is the foreign body. The answer is esophagus. Okay, very good. I think most of you are able to get it. Another thing that I talk about in all my classes is that if you have a brain abscess, you should always look for things like CSOM, sinusitis, or congenital heart disease in the question. Because why would you develop an abscess? There has to be a source of infection somewhere. So infection could be in the sinus, could be in the ear. So this patient had chronic ear discharge and fever. CT scan had a temporal lobe ring lesion with surrounding edema. The answer was temporal lobe abscess, complicating the CSOM here. And when you look back at your DAMS classes, you will see we had exactly discussed this entire concept with you. Okay. And this is not a soft tissue in the neck. I think somebody is getting it wrong. Okay. Somebody is telling it is 5. Okay. And almost the similar image was there. I talked to many students and then I zeroed down that this was the most likely image that the students had seen in the exam. One simple question was there, that patient is started on radiotherapy. Which of the following is least affected by radiation exposure? So we all know spermatogonia, bone marrow tissue, GI intestine, GI mucosa. These are always asked as the radiosensitive tissue in our body. The neurons are relatively radioresistant. Okay, so the answer here was neurons in the brain, spermatogonia, the gonads. Remember, anytime you get confused, gonad, bone marrow, intestine, they are the classic radiosensitive tissue in our body, and that should always be in your mind. Okay, so one of the question I have framed myself. Okay, so don't mind my framing the question, because I just framed the image. The question, to what I could understand from students was, the question was, somebody with untreated spinal TB has swelling in the groin with limb inflection. So if you imagine now somebody with tuberculosis has flexion deformity of the hip. So we know that in TB you develop cold abscess, he would have developed psoas abscess. Anybody, where is the psoas muscle? So this is your psoas muscle. So the number here in my choices will be 4. I do not know the exact number in the real exam, but this was somewhere I feel radiology anatomy integrated kind of a question where you had to identify the psoas muscle. The question was identify the psoas muscle. I just created my own choices, so don't mind the choices here. Okay, are you clear? Okay, very good. I think most of you got it right. And so these are the actual images in the classes where we had already discussed all of this. So I'm very proud of it that we had 100% strike rate as far as radiology is concerned. Okay, schematic diagram was there, that's okay also, but still, you know, chili potato beta, do you agree कि नहीं? अगर इतना बढ़िया रेडियोलॉजी में दिख रहा है, ऐसा ही स्कीमेटिक में दिखेगा, उसमें और कुछ थोड़ी होगा, है ना? Okay, clear? Okay, so we are very happy to say that we had, you know, maximum strike rate with DVT, class notes, and must know. But मैं ये कह रहा हूँ कि एक चीज और मैं यहाँ कहना चाहता हूँ before I invite Dr. Anupma. I hope Dr. Anupma, can you speak and confirm that you are able to speak now?
Yeah, I think so.
Oh, ma'am, we can hear Dr. Anupma now. Wow, awesome. So before I hand over to her, I just wanted to make sure that I say this to you, and it is very important to be said, कि कोई भी exam, any result, anything in life cannot define what you truly are. You have multiple facets of personality. You have a role to play in your family, a role to play in your own life, role to play in your friend's life, role to play as a doctor, role to play as a specialist. So it's like, do not underestimate your all other roles just because एक एग्जाम खराब हो गया. I just wanted to say this कि अब बहुत सारे बच्चे आते हैं, सर मेरा एग्जाम खराब हो गया, मेरी जिंदगी बर्बाद हो गई. जिंदगी सिर्फ एग्जाम नहीं है, जिंदगी उसके बियॉन्ड भी है, जिंदगी बहुत बड़ी है. So please, and my purpose of delaying this session for 2-3 days was I did not want to create any anxiety in our बच्चास. मुझे नहीं चाहिए कि बच्चे पेपर वाले दिन आए वापस और मैं आंसर डिस्कस कर रहा हूँ और वो घबरा जाएं. So I thought let things settle down, and I want you to also settle down. Now you're adults, you are doctors, you are going to handle stressful situations in your life. एक एग्जाम अच्छा हुआ खराब हुआ कोई बात नहीं, लेट्स सी रिजल्ट कैसा आता है ना, उसको देखेंगे. जो होना था हो चुका है. सो लेट्स अप्रिशिएट इट कि आप सिर्फ एग्जाम नहीं है, आपकी जिंदगी सिर्फ एग्जाम नहीं है, आपकी जिंदगी मल्टी फेसेटेड है, उसके अंदर बहुत सारे भाग हैं. तो डोंट जस्ट गेट कंफ्यूज्ड बाय दिस. कई बार मतलब आई कीप मीटिंग डॉक्टर्स हु कीप सेइंग कि मेरा करियर ही मेरी जिंदगी है. सच नहीं है, जिंदगी उसके बियॉन्ड भी है. तो थोड़ा सा बैलेंस लाएं जिंदगी के अंदर. डोंट प्लीज डू नॉट बी ओवरवेल्म्ड बाय द एग्जाम, डू नॉट बी ओवरवेल्म्ड बाय एनीथिंग. आप चैंपियन हैं, आप चैंपियन रहेंगे, आप बहुत अच्छा करेंगे जिंदगी के अंदर. सो प्लीज स्टे पॉजिटिव, एंड आई थिंक विदाउट वेस्टिंग टू मच ऑफ टाइम आई विल आस्क डॉक्टर अनुपमा एंड डॉक्टर सौरभ टू फिनिश, देन मे बी वी कैन हैव अ हार्ट टू हार्ट टॉक इन द एंड ऑफ दिस सेशन.
Okay, so welcome to just 4 questions. Either the physiology questions have been hijacked by other people, or for some reason, I have been only able to gather 4 questions. And the first question, of course, this was a 7-year-old child with dehydration is given ORS. Glucose absorption in the gut occurs by which of the following? Now, in this case, the mechanism for glucose absorption from the intestinal lumen to the cell will be by SGLT1. SGLT1, and how glucose goes from the cell to the blood is via GLUT2, which is an example of facilitated diffusion. In the PCT, the main absorption is done by SGLT2 and GLUT2, but in the PCT, it is SGLT2 and GLUT2, but in the, SGLT2 and GLUT2, but here in the intestine, it is SGLT1 and GLUT2. So this is the first question. The second question which has been asked is catecholamine action on a G protein. G protein coupled beta 2 adrenergic receptors mediated by which of the following enzymes? G protein coupled receptor, beta 2 adrenergic receptor, which is a G protein coupled receptor. This is linked with adenylate cyclase. Adenylate cyclase will cause the conversion of ATP to cyclic AMP, which in turn converts an inactive protein kinase to an active protein kinase, which is responsible for all the responses in the cells. Catecholamines are the important hormones which are going to act via the adenylate cyclase mechanism. So this was pretty simple. This was adenylate cyclase. There was another question which said fluid with sodium of 10 milliequivalents per liter and potassium of 140. I think we do this so often in class. A high potassium with a low sodium. This is the ICF. This everybody should have got it right. Excellent. Excellent. Fantastic. Everybody seems to have got it right. Okay. So, sorry. Yes, and a 40-year-old patient with ptosis and fatigue, which worsens towards the end of the day, is likely to have which of the following? Now, a disease of the presynaptic membrane is Lambert-Eaton syndrome, where the antibodies against voltage-gated calcium channels, and the disease of the postsynaptic membrane is myasthenia gravis, where antibodies against acetylcholine receptors. The one very important distinguishing feature, which I repeat so often in class, and that is in the case of Lambert-Eaton syndrome, the weakness will improve as the day progresses. And that is the reason for that is because of repeated stimulation, there is accumulation of calcium in the nerve terminal, causing more release of acetylcholine. Whereas in myasthenia gravis, the weakness worsens as the day progresses. And the reason for that, like I keep telling you, is because repeated stimulation is going to produce an exhaustion of the neurotransmitter. So the answer here is, it was written improves with exercise or worsens. The general consensus I've got is worsens towards the end of the day. Venetia, this is what the general consensus is, that worsens towards the end of the day, then it is myasthenia gravis. So in that case, this should be myasthenia gravis. So these are the 4 questions which I have been able to get from students as far as physiology is concerned. Like I said, possibly physiology questions have been hijacked by the other faculty, have not been able to get it, or either there may be a couple of more physiology questions which would have been probably very simple. So I have not been able to get that as a recall from students. Okay, so I think general consensus is worsens towards the end of the day. Then your answer has to be myasthenia gravis. Yes? Okay, great. So these are the 4 questions from my side. I think Dr. Saurabh? Dr. Saurabh, would you like to?
Yes, ma'am, I'm here.
Yeah. Thank you, everybody. Good luck, and thank you, and good night. Thank you.
Can you stop sharing, please?
Yeah. Is it okay? It's gone now?
Yes, ma'am.
All right, fine. Thank you.
I think it's visible now. It's visible. My slides are visible.
Yes, they are. Yes, they are.
All right. Hi, good evening, everyone. Almost good night, everyone. So we will discuss ophthalmology questions now. As ma'am said, some questions were hijacked in physiology. Ma'am also hijacked one question of mine, that is myasthenia gravis. So I'm not included that question. All right. So let's see the first question in ophthalmology. First question is, where is the likely lesion if the patient cannot see the right visual field from both eyes? So it means whenever a visual field question is asked, it has to be the patient's view. Okay, so if this is the right eye visual field, this is the left eye visual field. The question was the right side was not seen by the patient in both eyes. Means it has to be right homonymous hemianopia. So right homonymous hemianopia is classically seen in a retrochiasmal lesion, and that is at the level of left occipital, left optic tract. Okay, so right homonymous hemianopia, that is seen in left optic tract lesion. That was the first question. That was easy question. You must have answered this question. easily. Occipital lobe will cause, left occipital lobe will cause right homonymous heminopia with macular sparing. Optic chiasma will cause bitemporal defects, and right optic nerve will only cause, if the right optic nerve, it will only cause a unilateral defect of the right, that is right anopia. So that was the easy question. Left optic tract was the answer, and many of you must have got it right. Same thing. For example, I did in one class. This is left homonymous heminopia that is seen in right optic tract lesion. Retrochiasmal or contralateral homonymous. Right. Okay. Next question. Achha, this question has been discussed with Sumer sir. Person with chisel injury. Chisel injury, and some people are saying, say it was a stone injury or a chisel injury. So chisel injury is the iron. Iron, when you chisel a stone with the iron, so iron particles go inside the eye. So that was a question of metallic foreign body. That's why detrimental. Some people are saying sir detrimental नहीं पता क्या होता है. Detrimental English देखो English हमारी अच्छी होनी चाहिए. कुछ questions English से भी solve हो जाते हैं. So detrimental means which is not to be done. So MRI not to be done, which we discussed already. Investigation of choice or which is most useful is non-contrast CT scan, but that was not the question. It was detrimental. That was MRI. Okay, so English should be good. Okay, some are inert foreign bodies like gold, silver, platinum. Okay, so if you have a lot of them, you can keep in your eyes because they are inert foreign bodies. So that was not the question. The metallic foreign bodies, MRI is contraindicated. All right. Okay, so this was a pure ocular question. Most common complication of the condition. So this is a defect of the upper eyelid, and this is nothing but a coloboma. So coloboma is caused due to failure of embryonic fissure. Yeah, chili potato is answering right. So even if the patient closes his eyes, the cornea, kerato means cornea should be exposed. That is the answer to the question. Cataract, amblyopia, restricted movements can be some associations, but directly answer from this. This is a logical question. If you close your eyes, cornea is exposed. When you are not able to close eye because there is a coloboma that is exposing the cornea, that is the answer of this question. See, coloboma can be anywhere. There is a failure of closure of embryonic fissure. It can be iris coloboma. I always say iris coloboma is more important. Eyelid coloboma, I showed this, and cornea exposure. You see, cornea exposure has to be there. That is straight from the class. There can be lens coloboma, optic nerve coloboma also. 36 days, the coloboma closes. Failure to close is failure of embryonic fissure is coloboma. This question was taken by biochemistry, hijacked by biochemistry, ma'am. Glycogen of glycan maintains the corneal transparency. Most common glycogen of glycan is keratin sulfate that is present in the cornea. It maintains the stromal pressure. It is 60 pressure. That's why the intraocular pressure, how it maintains the corneal transparency, because the intraocular pressure is 21, less than 21. Cornea pressure is about 60. So it does not allow the aqueous to imbibe. And that's why what is the clinical implication? When the intraocular pressure is very high, more than 50, 60, 70, it imbibes into the cornea, leading to acute diffuse corneal edema. So that is how it maintains the transparency. And diffuse corneal edema can cause colored halos. Right? So keratin sulfate was the answer. Okay, so most awaited question in this. A 15-year-old child, 15-year-old was the age given, and that is the most important point you have to take care in this. With recent non-acceptance of the regular glasses, and the patient was having myopic, means negative power was there, and astigmatism means cylinder power was additional. So he was not willing to wear his spectacle glasses. What is a viable option in this case? So only question they wanted to ask your presence of mind at the exam that you are not missing the age, because the refractive surgery, any refractive surgery is not done before 18 years of age. If it is for professional activities, and less than 21 years of age, it is for cosmetic activities. So 15 years of age, refractive surgeries are not done. And this is again an English spherical equivalent spectacles, not spherical glasses. This is spherical equivalent, means patient does not want cylinder. So give equivalent of the cylinder in spherical power. That is a spherical equivalent spectacles, and that was the answer to this question. Okay, they will not ask at your level to choose between LASIK, femto-LASIK. That is not the question. Okay, and it does not suit the question. Only the criteria you have to take care in this is the age. Age less than 15 years of age, you cannot do refractive surgeries. So it was a trick question, but this was a differentiating question for your getting a good rank. Good. Good, Rishabh. Nice. So even in the class, I told you, contraindication of refractive surgeries is age less than 21 years for cosmetic purposes. All right. A retina question. The given sign is probably seen in which of the following? So it was identification of the sign. So what is the sign over here? This is a left retina, and you can see the sign. These are small shiny things, and these are hard exudates. Soft exudates look like cotton wool spots. आपके घर में cotton wool spots ऐसे नहीं दिखते हैं. Cotton wool spots are soft exudates. So this is mostly seen in diabetes mellitus, diabetic retinopathy, hard exudates. And if you can see, same I told you in class, this is the cotton wool spot, which looks like a soft exudate or a cotton wool spot. And in diabetic retinopathy, more of exudation is there. So more of hard exudates are present. Less of soft exudates are present. In hypertension, more of soft exudates are present because it is more of ischemia and less of hard exudates are present. All right. Of course, the yellow one has to be exudates. Hemorrhages should be red. So this you can see, this is a flame-shaped hemorrhages in the nerve fiber layer, and the others are dot knot hemorrhages, which is seen in deep vessels layer. Yes, curious dog. You're very curious to know the LASIK can treat astigmatism. Yes, LASIK can treat astigmatism as well, but that was not the case. LASIK has to be done at a particular age. After 18 and 21 years of age, LASIK is done. So 15 years of age, LASIK is not done, or any refractive surgery is not done. Okay, a newborn child with big eyes. That was one point. Big eyes. Blue. There's nothing like blue cornea. I just told you, whenever the intraocular pressure is very high, the cornea becomes diffuse corneal edema. That's where the patient appears as blue cornea. So big blue appearance of the cornea with watering. Out of these four options, only big eyes, ophthalmos is seen in congenital glaucoma. Watering can be there in ophthalmic neonatal, but no big eyes. Cataract, no symptom at all, no big eyes. Mucopelvic saccharoidosis, there can be haziness of the cornea, but there is no big eyes and no watering is there. So answer has to be congenital glaucoma. In fact, first and the most common symptom which a mother can see in the child is watering only. Then ophthalmos is a classical sign. There can be habstria. Okay, so answer has to be congenital glaucoma. Okay, the next question which you made a mistake. That was an easy question, but you made a mistake. You saw this picture. The question was the patient was coming with contact lens used for 2 years. Now come with irritation of eyes and the sign given in the pic. The sign everyone noted that this is a papilla. And you correlate with vernal keratoconjunctivitis, and you marked straight away vernal keratoconjunctivitis, cobblestone appearance. This is papilla, but you have to check contact lens use. If there's a contact lens use, that can also cause allergy in the conjunctiva, in the palpebral conjunctiva. So answer here is giant papillary conjunctivitis. Good eclipse. Naam eclipse of the very good eclipse. Good Stony, right. Even in the class, I told you conjunctival papilla is seen in vernal keratoconjunctivitis, but differential diagnosis is contact lens allergy. Giant papillary, if contact lens is given, that was straight away. Contact lens is given, giant papillary conjunctivitis has to be the answer. All right. Follicular conjunctivitis trachoma will cause most follicles. Okay. Here it was papillary. Okay. History of dryness, corneal softening, night blindness. So rods are important for night vision. So if there is a night blindness, it has to be vitamin A, that is retinoic acid. I think biochemistry discusses. But what happens, vitamin A is also responsible for goblet cell functions. If goblet cell functions are not there, mucus will not be produced and the cornea will become dry. That is xerosis. That is nothing but vitamin A deficiency. Answer, retinoic acid, a simple question. Night blindness, xerosis of the conjunctiva, xerosis of the cornea, malacia, melting of the cornea, that was softening. Cornea softening is there, night blindness, gritty sensation because of the dryness. All are suggesting retinoic acid, that is deficiency of vitamin A. That was an easy question as well. Good. Okay, a child presented with unilateral, I think pathology has hijacked pathology. It discusses unilateral white pupillary reflex, that is leukocoria. Surgery was done, biopsy specimens for flexor winter strainer, rosettes. Possible diagnosis out of these in eye orbit, retinoblastoma causes flexor winter strainer rosettes. That is the answer. Rhabdomyosarcoma is also round cell tumor. No rosettes are there. Desmin immunohistochemistry is positive. Retinoblastoma, synaptophysin is positive. So retinoblastoma has to be an important topic. Round cell tumor is there. Synaptophysin is positive is there. Leukocoria is the most common presentation. That was in the question as well. So answer is straight away retinoblastoma. That is also discussed. Here, and Dr. Sumer said discussed, ankylosing spondylitis, bamboo spine appearance. A young male, what was happening in the eyes? It is having acute red eyes because of acute non-granulomatous anterior uveitis. That is causing ankylosing spondylitis. All right. This was in the pharmacology. I saw Dr. Thiru discussed. The only glaucoma drug which is in this is latanoprost. the only glaucoma drug. So it was an easy question because you can only see which is a ocular drug which is given. So latanoprost was the answer. That is the drug of choice given in open angles and closed angles. That's the only ocular drug over here. All right, I think that were the questions. I think 13, 14 questions are there, but some were overlapping. So 10 actually were opthal and some 4 were overlapping with others. That will be from my side, a quick one. I think many have told that they have done well. Out of the 10, at least one, the LASIK one, which you made mistake, you didn't see the age. And second, the vernal keratoconjunctivitis, you marked it in haste. So these 2 questions were a little tricky, but otherwise, those who have answered these 2 questions, they can expect a good rank. Okay, so I think 8, if you get more than 8, that is good enough in ophthalmology in this exam. All right. All right, sir. So I'm done.
I think, thank you, Dr. Saurabh. I think wonderful discussion today. And I just wanted to let the students know that we have now covered 10 subjects. Remaining, we will cover tomorrow at the same time, 9:30 on this very channel. We have already done 10 subjects. For those of you who have joined late, let me just highlight, we have done radiology, ophthalmology. You can see us on the screen. We have done obs and gynae. We have done physio, anat, biochem, patho, pharma, PSM, psychiatry, I think. We've covered all of them. If I'm forgetting anything, we've done 10 subjects, and this is very important. And I also want you to know that now I can see already when I talk to students, there are students with concerns, sir, mera ye galat hua, ye theek ho gaya, or you have concerns ki mujhe milega ki nahi milega, mera exam is baar acha nahi hua, agli baar dena hai, and we have all those kind of doubts in our minds. My only thing is that we have to understand, for a competitive exam, it is just a combination of 3 things. Those 3 things, if you master, you will do very well. Number 1 is content. And that is where, I hope, you will all agree today that when you talk to the DAMS faculty members and the students of DAMS, you will realize that, okay, they had an edge that, okay, they had the correct content, the correct notes. You could see many of those things were discussed in the classes themselves. So that is content. But if you add to content exam skill, you start doing better and better. Exam skill means that you need to give more tests, more. Like I keep seeing students asking, sir, how to avoid silly mistakes. Revise your content multiple times, give more and more tests. More tests you give, better you become in your exam skills. But here I also wanted to show and tell you the third ingredient of success. भाई आपके एग्जाम स्किल भी आ गया और कंटेंट भी आ गया, फिर भी नहीं जीत रहे. क्यों नहीं जीत रहे? आखिरी क्या चाहिए? आखिरी है माइंडसेट. आप कैसे देखते हो दुनिया को, बहुत जरूरी है. व्हाट इज योर पर्सपेक्टिव टू लाइफ? नाउ हाउ डू यू लुक एट एन एग्जाम? डू यू लुक एट एन एग्जाम एज अ पनिशमेंट? क्या आपको लग रहा है कि एक बहुत मुसीबत है, किसी तरह खत्म करनी है, तो फिर रैंक कम आएगा. लेकिन अगर मैं सोचूं कि एग्जाम एक अपॉर्चुनिटी है मेरे लिए टू टेक मी टू द नेक्स्ट लेवल, लेट्स ट्राई एंड सी हाउ व्हाट दिस गेट लीड्स मी टू. You will look at the entire process like a journey rather than as a destination. आप उसको सोचो कि यार ये तो एक मौका है. Okay, so now this also answers the question, sir, should I give the INI-CT exam in November? Definitely you should. There is another opportunity waiting for you. No sir, अरे वो तो punishment एक और हो जाएगा. Then your perspective is wrong. How you look at an exam, how you look at an opportunity is going to define you. People will look at an exam as an punishment. Some people will look at it as an opportunity to go to the next level. What is your perspective? That is the key. How you look at life, how you look at situations will help you to go to the next level. Do not, again I'm repeating, do not be overwhelmed by some mistakes that you might have made in the exam. We have only answered based on the recall that we could collect. There could be some ifs and buts over the recall, because that is how the case is with the students recall every year. We have tried our best, but whenever the students recall, sometimes some students will say यहाँ पे true पूछा था, कोई बोलेगा all except पूछा था, वो रहेगा. तो don't be like, ये मत सोचो कि सिर्फ आपसे गलती हुई है, बाकियों से भी गलती हुई होगी. Don't panic. Don't think that we are not here to declare results. We are not here to pass a judgment on you. We are here to support you, give you the idea on what we think would have been the answers to the questions that we feel were there based on the student recall. But it's the entire idea is it's a learning experience. If somehow you can detach yourself from the outcomes in most challenging situations in your life, if you can remove the emotional component to it, थोड़ा सा उससे बाहर आ जाते हैं, एग्जाम से इमोशन है ना उसको हटा देते हैं, उसको एक गेट की तरह देखते हैं, you will be able to do better. You will be able to do better and better in life, and you will feel more and more positive about things. It is my pleasure and my honor to be able to help you all in this journey. And I'll ask Dr. Saurabh also to if he wants to give a final message to the students. Anything, Saurabh, from your side? Saurabh, you're on mute.
Yeah, sorry. Many students are asking if they can see the recorded version. Yes, of course, it is YouTube. You can see the recorded version later on. And then we have made the videos also in each subject. That also will be uploaded soon. But this session you can see on the YouTube.
So this is the key session where we are giving the answer key.
Yeah.
The detailed explanation session is available on the eMedicos app, and we are uploading subjects. I think next 2-3 days, all subjects, detailed explanations for the future aspirants will be uploaded, as is customary in DAMS, that every year we do a detailed discussion of the paper, and it is already there on the app. So we have started to upload videos on the eMedicos app. And I also want to take this moment on behalf of every teacher. We want to wish you all the best for your results. We are very, very excited about your results. We are sending all our best wishes, all our blessings to you. Stay positive, and stay optimistic about the results. Also, please remember, we are in a very, very unique year where this NEET PG has been delayed, obnoxiously delayed. And so the INI CET exam is very close. So it's a very good opportunity to actually to do a little bit more continuing your study and have a good chance at the central institutes. And also remember, the NEET PG 2022 will happen earlier. So it might happen in around April. So you might have 6 months from here onwards. So in DAMS, we have now tailored all our courses, our regular course, our TND course, to 6 months. And one more announcement is, after that in 2023, the pattern will change and we will have next exam. So it's important to remember 2022 will be the last NEET PG in the current format. And you know that we have to make it happen. I also want to tell you कि अगर पेपर में थोड़ा गलती हुआ है या कुछ हुआ है, उसको लेके बहुत ओवरवेल्म नहीं होना. एग्जाम आपकी जिंदगी का पूरा भाग नहीं है, सिर्फ एक हिस्सा है, जिंदगी उससे बहुत ज्यादा बड़ी है. On that note, I wish you all the best. Good night. Take care of yourself, and we will see you again tomorrow at 9:30, and we will cover the remaining topics. Thank you, Saurabh. Thank you all the faculty members for joining in, and thank you all the children. Best of luck, everybody.